Now, can all of you hear me? Now, I just wanted to see whether you can hear me. Uh, Hold on, just let me know whether I am audible now. Can all of you hear me? Yes? Okay, thank you. Okay, okay. So, starting the session without wasting much time. Today's session, it will be available on YouTube for tomorrow as well. And I'm going to take 3 years PYQs with you. June FMG 2021 session, then December 2021 session, and June 2022 session, right? So these are the 3 sessions we are going to take. First, we are going to cover questions of June 2021 session. So question number 1, an intern conducts a delivery and immediately after delivery, patient experiences breathlessness, hypotension, tachycardia and she collapses. Per vaginal examination is normal and there is no excessive blood loss. What is the probable diagnosis? अब ये जितनी भी obstetrical emergencies होती हैं उस पे a lot many times questions are being asked these days. Right? So whenever you get a question on postpartum collapse, question says patient goes into shock after delivery, there can be 3 possibilities. Number 1, PPH, number 2, uterine inversion, number 3, amniotic fluid embolism. अब क्वेश्चन की लैंग्वेज से कैसे पता लगेगा कि व्हाट इज द कंडीशन? अगर क्वेश्चन में मोस्ट कॉमन कॉज पूछा गया है, इट इज पीपीएच. अगर क्वेश्चन में दिया गया है कि पेशेंट हैज गॉन इनटू कोलैप्स आफ्टर एक्सेसिव ब्लीडिंग, then also this is PPH. If the question says कि excessive bleeding है and uterus is not palpable on per abdominal examination, that means it is a case of atonic PPH and again you are going to mark the answer as PPH. On the other hand, अगर question में word आया है immediate shock after delivery, then most of the times you are going to think about uterine inversion. In case of uterine inversion, जो shock होगा that will be out of proportion to bleeding. Per abdominal examination में a cup like depression will be felt and per vaginal examination में something round will be felt in the vagina. Then comes the third cause, that is amniotic fluid embolism. Right? अब amniotic fluid embolism में the one word which you might get is unexplained shock. So if your question says unexplained shock after delivery, mark the answer as amniotic fluid embolism. Now there is one typical feature जो किसी भी और केस में नहीं मिलता, केवल amniotic fluid embolism में मिलता है, that is breathlessness. So in case of amniotic fluid embolism, you are going to get breathlessness and there is going to be heart failure. So अगर क्वेश्चन में breathlessness के साथ heart failure के फीचर्स दिए हैं, definitely the answer is amniotic fluid embolism. Please remember amniotic fluid embolism में per abdominal examination normal होगा, per vaginal examination normal होगा. As far as bleeding is concerned, remember amniotic fluid embolism के 2 phases होते हैं. In the first phase patient में breathlessness मिलती है and heart failure मिलता है जिसमें bleeding कम होती है. सेकेंड फेज में पेशेंट हैज DIC जिसमें ब्लीडिंग ज्यादा होती है. तो इन एमनियोटिक फ्लूइड एम्बोलिज्म देयर कैन बी एक्सेसिव ब्लीडिंग, दे कैन नॉट बी एक्सेसिव ब्लीडिंग. राइट? फर्स्ट फेज में एक्सेसिव ब्लीडिंग नहीं होगी, सेकेंड फेज में एक्सेसिव ब्लीडिंग होगी. नाउ इन योर केस, नंबर 1 they are saying immediately after delivery. जब हमने immediately after delivery पढ़ा, my mind said it could be a case of uterine inversion. लेकिन next उसमें दिया है कि patient is having breathlessness, hypotension, tachycardia. Breathlessness, hypotension, tachycardia मिलता है amniotic fluid embolism में. Right? So now I want to know whether my patient is having amniotic fluid embolism या uterine inversion. आगे देखो, per vaginal examination normal दिया है, जबकि uterine inversion के केस में per vaginal examination में some round mass will be felt inside the vagina, fundus will be felt inside the vagina. So per vaginal examination कभी भी normal नहीं होगा. So remember this message कि कभी भी breathlessness दिया हो, heart failure के features दिए हो and patient has gone into shock, it means you are dealing with amniotic fluid embolism. Right? So this is a case of amniotic fluid embolism and this is not a case of uterine inversion. Please do not write that explain in English, explain in English. I will use both the languages and I will explain it to you, right? Then comes second, pelvis associated with persistent occipito-posterior position. Now, whenever you get a question on pelvis and your question is saying occipito-posterior position, Abhinandan, I will repeat only this much, that if your question is saying breathlessness and collapse, so patient has gone into collapse and your question says breathlessness, that means it is amniotic fluid embolism, right? In case of amniotic fluid embolism, per abdominal examination normal होगा, per vaginal examination normal होगा. यूट्राइन इन्वर्जन के केस में कभी भी ब्रेथलेसनेस नहीं मिलेगा. यूट्राइन इन्वर्जन के केस में पर विजाइनल एग्जामिनेशन कैन नेवर बी नॉर्मल, क्योंकि यूट्राइन इन्वर्जन का मतलब है कि यूट्रस का फंडस जो है वो इन्वर्ट कर गया है, एंड जब यूट्रस का फंडस इन्वर्ट करेगा तो ऑन पर विजाइनल एग्जामिनेशन यू विल गेट समथिंग राउंड felt inside the vagina, and that round is nothing but that round mass is fundus of the uterus, right? अब why is this not a case of PPH? ये PPH क्यों नहीं है? ये PPH इसलिए नहीं है क्योंकि क्वेश्चन में दिया है कि there is no excessive blood loss. Clear to all of you? Okay. Coming to questions related to occipito-posterior position. अगर question आता है in which pelvis occipito-posterior position is common, your answer will be android pelvis. In which pelvis deep transverse arrest is common, android pelvis. रट लो इस चीज को. But अगर question says persistent occipito-posterior position या direct occipito-posterior position, occipito-posterior position के आगे कोई भी prefix add हो गया, वो prefix चाहे persistent हो चाहे direct हो, now your answer will change to anthropoid pelvis, right? केवल occipito-posterior पूछेंगे तो your answer is android pelvis. persistent occipito-posterior पूछेंगे या direct occipito-posterior पूछेंगे, anthropoid pelvis. face presentation किस में common होता है? platypilloid pelvis. अब बहुत carefully answer करना. If they ask you face presentation is common in, your answer will be platypilloid pelvis. But if they say face to pubes delivery is common in, your answer is going to be anthropoid pelvis. Right? Clear? Okay. Coming to question number 3. A female has previous history of cesarean section, prolonged labor, she is hypotensive, fetal heart sounds cannot be heard, and fetal parts are superficially palpable. The diagnosis is. अब यहां पे बहुत क्लियर कट क्वेश्चन दिया है एंड क्वेश्चन कह रहा है दैट देयर इज प्रीवियस हिस्ट्री ऑफ सिजेरियन सेक्शन, मदर में हाइपोटेंशन मिल रहा है, टेकीकार्डिया मिल रहा है. ऑन पर अब्डोमिनल एग्जामिनेशन क्वेश्चन कह रहा है fetal parts are felt superficially. प्लीज रिमेंबर, जब भी क्वेश्चन ये कहे कि प्रीवियस हिस्ट्री है सिजेरियन सेक्शन की एंड मदर में विजाइनल डिलीवरी करा रहे थे हम, and now mother is going into shock, fetal heart rate, मदर की हार्ट रेट इंक्रीज हो रही है, मदर का बीपी डिक्रीज हो रहा है, पर abdominal examination में fetal parts are felt superficially. It means कि यूट्रस रप्चर कर गया है, तभी fetal parts superficially felt हो रहे हैं, and that is why mother has gone into shock. Now, instead of saying this, that the fetal parts are felt superficially, your question next time, day after tomorrow, can say that uterine contractions are not felt and a gap is felt in the uterus. तो अगर ये भी दे रहे हैं कि a gap is felt in the uterus, then again it means it's a case of uterine rupture. In a case of uterine rupture, fetal heart sounds will not be heard. पर विजाइनल एग्जामिनेशन में हिमचूरिया मिलेगा, फ्रेश ब्लीडिंग मिलेगी, एंड अभी तक जब when we were doing per vaginal examination, fetal head was being felt. लेकिन जब once the uterus ruptures, fetus is lying in the peritoneal cavity. तो अब जब हम पर vaginal examination करेंगे, you will not feel fetal head. अब ये question में कैसे दिया होगा? In the question it will be written as loss of fetal station. So if you get this line, there is loss of fetal station, immediately it means it is uterine rupture. गैप का मतलब है कि यूट्रस जब रप्चर होगा तो यूट्रस में एक गैप फील होगा ना, कोई भी चीज फट रही है, कोई भी चीज रप्चर हो रही है तो एक गैप फील होगा, राइट? नाउ दिस शुड बी वेरी मच डिस्टिंग्विश्ड फ्रॉम another situation. अगर आपका क्वेश्चन ये कहता है that mother is in prolonged labor and after prolonged labor जब per abdominal examination किया तो upper segment is contracted and lower segment is relaxed, Bandel's ring is felt. Now the moment your question says Bandel's ring is felt, then it is not a case of uterine rupture. Bandel's ring feel होती है in case of obstructed labor, right? तो obstructed labor अगर होगा तो question में Bandel's ring दिया होगा, क्वेश्चन में दिया होगा कि there is hot dry vagina and foul smelling discharge. यूट्राइन रप्चर के केस में दिया होगा fetal parts are felt superficially, on per vaginal examination there is loss of fetal station, right? यूट्राइन रप्चर का मैनेजमेंट है कि इमीडिएट लेप्रोटमी करो, ऑब्स्ट्रक्टेड लेबर का मैनेजमेंट है कि इमीडिएट सिजेरियन सेक्शन करो. क्लियर टू ऑल ऑफ यू? यस. सो यहां पे क्योंकि दिया है fetal heart sounds are not heard and fetal parts are palpable superficially, it means it's a case of uterine rupture. Clear to all of you? Yes. Now, why cannot it be hydroamnios? Hydroamnios का मतलब है excessive amniotic fluid. जब excessive amniotic fluid है तो fetal heart sounds नहीं सुनाई देंगे, agreed. लेकिन polyhydramnios के केस में patient hypotensive क्यों होगी? Right? Why is she going into shock? Number one. Why are they saying fetal parts are felt superficially? राइट? हाइड्रामनियोस का मतलब है कि आप फीटल पार्ट्स फील ही नहीं कर पाओगे, सुपरफिशियली तो दूर की बात. क्लियर टू ऑल ऑफ यू? यस. नाउ नेक्स्ट क्वेश्चन. नाउ समवन इज आस्किंग कि इफ देयर इज यूट्राइन रप्चर तो क्या होगा? यूट्राइन रप्चर होगा तो फीटल डेथ हो जाएगी एंड आप लेप्रोटमी करोगे, फीटस जो डेड फीटस है उसको बाहर निकालोगे एंड यूट्रस को स्टिच करोगे, राइट? या उसकी हिस्ट्रेक्टमी कर दोगे अगर यूट्रस रिपेयरेबल कंडीशन में नहीं होगा तो. देन 32 वीक्स प्रेग्नेंट फीमेल कंप्लेन्स ऑफ विजाइनल ब्लीडिंग, right? On per abdominal examination uterus is tender, fetal heart sounds are absent. Now please remember, whenever your question says that there is bleeding beyond 28 weeks, that means they are talking about antepartum hemorrhage. Antepartum hemorrhage का differential diagnosis होता है preterm labor. प्रीटर्म लेबर एंड एंटीपार्टम हैमरेज को हमें डिस्टिंग्विश करते हुए चलना होता है. नाउ इन एंटीपार्टम हैमरेज दे कैन बी टू कंडीशंस. आई एम श्योर ऑल ऑफ यू नो दैट प्लेसेंटा प्रेविया, अब्रप्शियो प्लेसेंटा. प्लेसेंटा प्रेविया में कैसी ब्लीडिंग होती है? पेनलेस ब्लीडिंग होती है, कोई रीजन नहीं होता उस ब्लीडिंग का. ब्लीडिंग इज ब्राइट रेड इन कलर. Uterus is non-tender, fetal heart sounds are easily heard, and height of the uterus is equal to the period of gestation. In case of placenta previa, per vaginal examination is contraindicated, but the investigation of choice is TVS. Whereas in case of abruptio, there will be bleeding, but bleeding के साथ pain in abdomen present होगा. There will be history of trauma or PIH. Then bleeding will be dull red in color, uterus will be tensed and rigid. That is why fetal heart sounds will not be able to hear. and because of concealed variety of bleeding, height of the uterus will be more than period of gestation. In case of abruptio, per vaginal examination is not contraindicated. अब antepartum hemorrhage के केस को प्री टर्म लेबर से कैसे डिस्टिंग्विश करोगे? Now प्री टर्म लेबर में भी ब्लीडिंग मिलती है, but that is actually show it is blood mixed mucus discharge. And जब पेशेंट प्री टर्म लेबर में होगी तो fetal heart sounds normal होंगे, height of the uterus will be equal to the period of gestation. यूट्रस कॉन्ट्रैक्ट करेगा एंड रिलैक्स करेगा, ऐसा कभी भी नहीं होगा कि यूट्रस टेंस्ड एंड रिजिड होगा. And when you will do per vaginal examination, you will see that the cervix is progressively dilating. तो धीरे धीरे cervix dilate हो रहा है. So that means you are dealing with preterm labor. अब इस केस में per abdominal examination में uterus is tender, fetal heart sounds are absent and bleeding है. So this means this is a case of abruptio. It is not a case of preterm labor. Why it is not a case of preterm labor? क्योंकि fetal heart sounds normal होनी चाहिए. Uterus tender नहीं होगा, uterus contract and relax करेगा. Right? It is not a case of placenta previa क्योंकि placenta previa के केस में uterus कभी भी tender नहीं होता. It is not a case of uterine rupture क्योंकि uterine rupture प्रीवियस हिस्ट्री ऑफ सिजेरियन सेक्शन के पेशेंट्स में मिलता है, यहां पे ऐसी कोई हिस्ट्री इन्होंने दी नहीं है. राइट? एंड यूट्राइन रप्चर मिलता है जब प्रीवियस हिस्ट्री ऑफ सिजेरियन सेक्शन के पेशेंट्स दे गो डिलीवरी, दे आर डिलीवरिंग, उस टाइम पे मिलता है. कभी भी ऐसे ही ड्यूरिंग प्रेगनेंसी यू डोंट गेट यूट्राइन रप्चर. राइट? सो इन यूट्राइन रप्चर you will get, the question will specifically tell you that there is previous history of cesarean section, and question is going to tell you that patient is now in labor. Right? Uterus doesn't rupture spontaneously during pregnancy. There has to be a reason for the uterus to rupture. Clear? Now, coming to question 5. A pregnant female visits antenatal OPD for the first time. At 18 weeks of pregnancy, her fundal height corresponds to 16 weeks. In other words, the question is saying that the height of the uterus is less than the period of gestation. Right? So, you have to tell me what are the conditions in which height of the uterus is less than the period of gestation. Number 1, if it is, wrong dates. So, if patient doesn't know her dates, then in case of intrauterine death of the fetus, in case of IUGR, in case of transverse lie, and in case of oligohydramnios. Right? Now, in this case, the question is asking you in which of the following conditions you are going to get height of the uterus less. So, please remember, fetal renal agenesis leads to oligohydramnios. Fetal anemia, anencephaly and Barter's syndrome, all of them, they lead to polyhydramnios, and in polyhydramnios, height of the uterus is more than the period of gestation. Barter's syndrome is one renal condition of the fetus in which you get polyhydramnios. Otherwise, in all renal conditions of the fetus, you get oligohydramnios. Barter's syndrome is one renal condition of the fetus where you get polyhydramnios. And if you are a Marrow subscriber, you know I have taught everything there in your Marrow videos. Right? Coming to the next question. A 25-year-old P1L1 delivered 12 weeks back, and she gives history of continuous heavy bleeding per vagina. She has history of dilatation and curettage in some private hospital. The most likely explanation for the bleeding is. So I will come to this in a moment, that what is the answer. But first tell me, if a patient is coming to you with bleeding, right, after delivery, most of the times that's a lochia, right? And lochia, when is lochia normally seen? What is lochia? Lochia is shedding of decidua after delivery. Normal time for lochia is 24 to 36 days. Very, very important. Remember this for your upcoming exam. Second important thing is the sequence of lochia. Lochia rubra, then serosa, and then alba, right? Then, so lochia cannot continue up till 12 weeks. This patient she had delivered 12 weeks back. So this cannot be a case of lochia. right? Then comes PPH. Now, PPH can be primary PPH. Primary PPH happens within 24 hours of delivery, or secondary PPH. Secondary PPH happens from 24 hours to 12 weeks after delivery. And since this patient delivered 12 weeks back, I may think that this is a case of secondary PPH. Now, the most common cause of primary PPH is atonic uterus. Most common cause of secondary PPH is retained placental tissue. And management of retained placental tissue is कि आप DNC कर दो, right? If some part of the placenta is retained inside, if some tissue is retained inside, when I will do a curettage, that part will come out. Right? And now question is saying that she had undergone a DNC but still she is bleeding. So this means I can rule out PPH, that she is not a case of PPH, right? Because if she would have been a case of PPH after DNC, her bleeding would have stopped, right? Is that clear to you? Now, then comes, has she developed DIC? Do you think a patient of DIC presents to you like this? That for 12 weeks she has been bleeding and patient is coming to you with vitals stable, telling you that I have been bleeding for past 12 weeks? No. DIC is an emergency situation. Patient comes to you with excessive bleeding and in shock, right? So it cannot be a case of DIC. Right? This means by ruling out all the other options, this is a case of gestational trophoblastic neoplasia. Please remember that GTN most commonly develops after H-mole evacuation. Most commonly, they are going to develop after H-mole evacuation. And the most common GTN to develop after H-mole evacuation is invasive mole. Please do not say choriocarcinoma. But then GTN can also happen after abortion. GTN can happen after ectopic pregnancy. GTN can happen after normal delivery. And the most common GTN after normal delivery is choriocarcinoma. Overall, the most common GTN is invasive mole. So whenever a patient comes to you with persistent bleeding after molar evacuation or persistent bleeding after normal delivery or after abortion or after ectopic pregnancy, one of the differential diagnoses is GTN. Clear to all of you? Yes? Okay. Then, a 25-year-old primigravida is on lithium for treatment of psychiatric illness for past 2 years. The most common anomaly seen in fetus with a mother who has taken lithium during pregnancy is, this is a very, very straightforward question. If you are a Marrow subscriber, I have taught you this, that lithium leads to Epstein anomaly. Right? Now this over here, I am telling you most important drugs and their teratogenic effects. Lithium leads to Epstein anomaly, and in Epstein anomaly there is malfunctioning of the tricuspid valve. Warfarin leads to warfarin embryopathy. In warfarin embryopathy, हमें cartilage formation defective मिलता है. There is chondrodysplasia which is seen in warfarin, which is going to affect the cartilage. Cartilage is not formed, so you get nasal cartilage hypoplasia, nasal bone hypoplasia, and you get stippled epiphysis. Misoprost ka use leads to Mobius syndrome. Retinoic acid, that drugs like isotret, they lead to anosia or microtia. Thalidomide leads to phocomelia. In phocomelia, you have proximal limb defect, right? So that there is a proximal limb defect in phocomelia. Then alcohol use leads to fetal alcohol syndrome. In fetal alcohol syndrome, you will get growth restriction, microcephaly, small head, and typical facial features. In typical facial features, you have small eyes, a smooth philtrum, and a thin upper lip. Right? So these are the features which you get with fetal alcohol syndrome. Growth restriction, plus microcephaly plus typical facial features, right? And phenytoin use leads to fetal Hayden-Toyne syndrome. In fetal Hayden-Toyne syndrome, again, there is going to be microcephaly. There can be cleft lip, cleft palate, and underdeveloped fingers, right? So this table over here, I want all of you to quickly take a screenshot of this table over here and just revise it before you sleep today. Yes? Okay. Coming to next question. A 26-year-old female with mechanical valve on warfarin therapy has a pregnancy test positive. The best advice to give her is, very, very important is anticoagulant use during pregnancy. Now, if the patient has a bioprosthetic valve, प्लीज रिमेंबर बायोप्रोस्थेटिक वाल्व का पेशेंट में प्रेगनेंसी के टाइम पे नो एंटीकोगुलेंट इज नीडेड एंड नॉर्मली ऑल्सो नो एंटीकोगुलेंट इज नीडेड फॉर बायोप्रोस्थेटिक वाल्व्स. The only thing which you need to give to patients of bioprosthetic valves is aspirin. Coming to mechanical valves, जैसा कि क्वेश्चन में दिया है, she had mechanical valve. Mechanical valve के पेशेंट को anticoagulant भी देना है during pregnancy and aspirin also has to be given during pregnancy. In first trimester, the best thing to do is to put her on low molecular weight heparin, right? Or if the dose of warfarin is less than 5 milligrams, you may continue warfarin, but the best thing is to switch over to low molecular weight heparin. This is something which is new, which has come up, that warfarin, if the dose of warfarin is less than 5 milligrams per day, it can be continued in first trimester, right? अब जैसे ही फर्स्ट ट्राइमेस्टर ओवर होता है एंड पेशेंट कम्स टू 12 वीक्स, देन बिटवीन 12 वीक्स टू 36 वीक्स, every patient is given, all pregnant females with mechanical valves are given warfarin. Then at 36 weeks, you are going to change and you are going to again put her on low molecular weight heparin. Why? Please remember two basic differences between warfarin and heparin. Warfarin can cross the placenta, right? That is a big problem with warfarin, but warfarin is a very strong anticoagulant drug and pregnancy is a hypercoagulable state. क्योंकि pregnancy hypercoagulable state होती है, so I need a strong anticoagulant. That is why जैसे ही 12 weeks over होते हैं, I put my patient on warfarin because I need a strong anticoagulant. Now at 36 weeks, again I put my patient on low molecular weight heparin. Why? Because if patient is on warfarin, warfarin is a very strong anticoagulant drug and that can lead to PPH. So again at 36 weeks, you have to shift your patient to low molecular weight heparin and you have to stop low molecular weight heparin 24 hours before vaginal delivery or cesarean section. When do you restart anticoagulant? You restart anticoagulant 6 hours after vaginal delivery or 6 to 12 hours after cesarean section. In practice, we start after 24 hours of cesarean section, right? Now, जब हम start करेंगे तो हम heparin and warfarin को एक साथ start करेंगे and once INR is achieved, 2 to 2.5 का INR achieve हो गया, then I'm going to stop heparin and continue warfarin. Why did I start heparin and warfarin after delivery? This is because warfarin takes time to act, जबकि heparin immediately act कर लेती है. So immediately act करने के लिए I started with heparin and then I also added warfarin and एक बार once the INR is stabilized, I stop heparin and I continue her throughout her life on warfarin. Right? Now, suppose your patient doesn't come to you at 36 weeks and patient is on warfarin at the time of delivery and they ask you what is the next step. So, please remember, if the patient is on warfarin at the time of labor, you have to stop warfarin. You have to do a cesarean section. You are not going to do a vaginal delivery and you are going to give vitamin K to the mother and vitamin K to the neonate once the baby is born, right? Clear to all of you? Alize, I told that you should stop low molecular weight heparin 1 week before delivery and switch over to unfractionated heparin. That is basically for NEET PG students. As an FMG student, you just need to remember कि 36 weeks पे हम low molecular weight heparin start कर देते हैं. Why I'm saying कि as an FMG student you need to remember this? Because FMG students में they are going to follow Datta, what Datta says, and Datta say doesn't tell you to switch over to unfractionated heparin. Right? Okay. Coming to the next question. The complication which is associated with IV bolus injection of oxytocin. Now, please remember, oxytocin, you should never give it IV bolus. Why you should not give it IV bolus? Because it leads to hypotension and ultimately it can lead to cardiac arrest. The other thing which you have to remember is oxytocin, you have to give it IM or you have to give it as IV infusion, right? And when you are making an IV infusion, you are going to make that infusion in ringer lactate or normal saline, and you are not going to make the infusion in dextrose 5% solution. Why not in dextrose 5% solution? Because it can lead to water intoxication. Water intoxication, right? That is why you are not going to use it in dextrose 5%, right? So IV bolus you don't give it because it leads to hypotension. Dextrose 5% में नहीं बनाते हैं because it can lead to water intoxication, right? Now quickly I want all of you to revise contraindications for methyl ergometrin. So if you are a Marrow subscriber, I have told you the mnemonic for contraindications of methyl ergometrin. They are TOPER. What is T? T is after delivery of first twin. You can give methyl ergometrin after delivery of second twin, but not after delivery of first twin. O stands for organic heart disease or any heart disease. P for preeclampsia, E for eclampsia, and R for Rh negative pregnancy. Now someone has asked me that why don't you give heparin in second trimester? As I told you, warfarin is a strong anticoagulant, heparin is a weak anticoagulant. राइट एंड प्रेगनेंसी जो होती है वो हाइपर कोआगुबल स्टेट होती है. प्रेगनेंसी में ऑल क्लॉटिंग फैक्टर्स आर इंक्रीज्ड, सो देयर आर वेरी हाई चांसेस ऑफ थ्रोम्बोएम्बोलिज्म इन प्रेगनेंसी. दैट इज व्हाई हम वॉरफेरिन को स्टार्ट कर देते हैं फ्रॉम 12 वीक्स, बिकॉज अगर हम हेपारिन कंटिन्यू रखेंगे, हेपारिन बीइंग अ वीक एंटीकोगुलेंट, देयर विल बी हाई चांसेस ऑफ थ्रोम्बोएम्बोलिज्म. Clear? Okay. So have you understood this? Contraindications of methyl ergometrin. Coming to next question. This is again a question which we do very oftenly in the Marrow videos. False statement regarding the instrument which is shown in the image. Now what instrument is shown in the image? The instrument which is shown in the image is MVA syringe, that is manual vacuum aspiration syringe, right? Now there are two syringes. One is manual vacuum aspiration syringe, other is menstrual regulation syringe. दोनों के बीच में डिफरेंस ये होता है कि मैनुअल वैक्यूम एस्पिरेशन सिरिंज में 2 पिंच वाल्व्स मिलते हैं. menstrual regulation syringe में you get a single pinch valve. Now nowadays what has started happening, ये अभी तक था, अब what has started happening is कि जो manual vacuum aspiration syringe है उसमें you may get a single pinch valve or you may get 2 pinch valves, and जो menstrual regulation syringe है वो एक normal syringe बन गई है. So now अगर आपके पास question आता है, चाहे वो ये syringe दिखाएं चाहे वो ये syringe दिखाएं, it means it is manual vacuum aspiration syringe, right? Manual vacuum aspiration syringe की capacity is 60 ml. प्रेशर जो ये सिरिंज जनरेट करती है, बेस्ट आंसर इज 660 millimeters of mercury. If 660 is not given, then the second best answer is 600 millimeters of mercury, right? And इस सिरिंज को हम till 12 weeks of pregnancy यूज कर सकते हैं. Now please remember that when you are doing MTP, up till 7 weeks जो बेस्ट मेथड होता है एमटीपी का, दैट इज मेडिकल अबॉर्शन. 7 वीक्स से 12 वीक्स के बीच में बेस्ट मेथड इज सक्शन इवैक्यूएशन. एंड ये सक्शन इवैक्यूएशन हम करते हैं विद द हेल्प ऑफ कार्बन कैनुला. एक प्लास्टिक कैनुला होता है, कार्बन कैनुला, जिस पे क्वेश्चन आया है, एंड आई विल शो यू जस्ट नाउ. एंड दिस कैनुला इज अटैच्ड टू अ सक्शन मशीन जो कि प्रेशर जनरेट करती है. सक्शन इवैक्यूएशन के लिए इलेक्ट्रिसिटी इज नीडेड, राइट, टू रन दिस सक्शन मशीन. सो रूरल एरियाज में जो ऑल्टरनेटिव होता है टू सक्शन इवैक्यूएशन, दैट इज मैनुअल वैक्यूम एस्पिरेशन. मैनुअल वैक्यूम एस्पिरेशन में ये सिरिंज यूज करते हैं, एंड ये सिरिंज जो है ये प्रेशर जनरेट करती है. कितना प्रेशर जनरेट करती है? 660 millimeters ऑफ मर्क्यूरी. 660 ऑप्शन में नहीं दिया है, तो सेकंड बेस्ट आंसर इज 600 millimeters ऑफ मर्क्यूरी, राइट? सो इट डजंट नीड इलेक्ट्रिसिटी, दिस इज राइट. It creates a pressure of 650 millimeters of mercury, right? इसकी कैपेसिटी 30 ml होती है, wrong. ये जो सिरिंज होती है इसकी कैपेसिटी होती है 60 ml, and it can be used for MTP up till 12 weeks, right? Okay, now coming to next question. A G4 woman who's 24-year-old presents at 22 weeks with previous history of 3 mid-trimester abortions. On ultrasound, her cervical length is 20 millimeters. What could be the most probable cause of her recurrent pregnancy loss? Right? So, over here, please remember recurrent pregnancy loss का मतलब है more than equal to 3 losses of pregnancy. एंड अगर अल्ट्रासाउंड ने कंफर्म करा था प्रेगनेंसी को, सो इट मींस मोर देन इक्वल टू 2 लॉसेस ऑफ प्रेगनेंसी. नाउ रिकरेंट प्रेगनेंसी लॉस का या रिकरेंट अबॉर्शंस का मोस्ट कॉमन कॉज और मोस्ट कॉमन ग्रुप which can lead to recurrent pregnancy loss is endocrine problems followed by uterine problems. Right? So endocrine problems are the most common reason for recurrent pregnancy loss. But if they ask you, अब endocrine causes में बहुत सारे causes आते हैं. So if they ask you the most common single cause for recurrent pregnancy loss, it is APLA. What do you mean by APLA? Antiphospholipid antibody syndrome. Right? Now, if the question comes, most common cause of second trimester recurrent pregnancy loss. Second trimester recurrent pregnancy loss is due to cervical incompetence. Cervical incompetence में patient complains of painless abortion. And कभी भी अगर आपको patient history दे रही है 2 second trimester recurrent abortions, so without any further investigation, it means she's a case of cervical incompetence. 2 second trimester recurrent abortions. लेकिन अगर patient आपको history दे रही है single second trimester recurrent abortion की, तो in that case you have to look at the length of the cervix, and if length of the cervix is less than 25 millimeters, then that's a case of cervical incompetence. So this over here is a clear-cut case of cervical incompetence because there is history of 3 second trimester abortions and there is cervical length is 20 millimeters. Please remember diagnosis के लिए या तो 2 second trimester abortions होने चाहिए. 2 second trimester abortions हैं तो it is sure-cut case of clear-cut case of cervical incompetence. Or 1 second trimester abortion plus length of the cervix less than 25 millimeters. Next question. A 24-year-old primigravida is having pain in abdomen. Her cervix is 1 centimeters dilated, 20% effaced. After 10 hours, her findings are same. Fetal heart sounds is normal and regular. What is the next step in management? So over here, quickly I'll tell you a few things. First stage of labor का मतलब है up till the cervix becomes 10 centimeters dilated. First stage में there is latent phase and active phase. According to ACOG, latent phase is up till 5 centimeters and active phase begins at 6 centimeters. जो recent WHO guidelines हैं जिसपे नया पार्टोग्राम based है. So this is a very very important question. New partogram, which is called as labor care guide, is based on new WHO recommendations, and according to new WHO recommendations, active phase begins at 5 centimeters. So परसों अगर you get a question that in partogram, in the new partogram, plotting is going to begin from, so plotting begins from 5 centimeters. Do not say 4 centimeters, right? Now, latent phase of labor को prolonged कहते हैं if it is more than 20 hours in a nulliparous female or more than 14 hours in a multiparous female. Prolonged latent phase का management होता है, you have to sedate the patient, you don't do any cesarean section. अब यहाँ पे your patient is just 1 centimeter dilated and 10 hours ही हुए हैं अभी, right? So इस case में हम क्या करेंगे? Am I going to start oxytocin? Am I going to do ARM? Am I going to do cesarean section? No, I am going to sedate the patient. Please remember, ARM कब करते हैं या ऑक्सीटोसिन कब देते हैं? ARM या ऑक्सीटोसिन is given for protracted active phase. Protracted active phase का मतलब होता है if dilatation is less than 1 centimeter per hour in active phase. So if your question says that patient is in active phase and the dilatation which is happening is less than 1 centimeter per hour, then your answer will be ARM or oxytocin. Cesarean section answer कब होगा? Cesarean section answer होगा अगर question में fetal distress दिया है, then you are going to do, say I'm going to do a cesarean section. या अगर question में दिया है कि patient active phase of labor में है, 4 hours have passed and there is no further dilatation, which is called as active phase arrest, right? So active phase arrest का मतलब है कि patient active phase में है, 4 hours हो गए हैं and कोई भी dilatation नहीं हुआ. So suppose patient was 6 centimeters dilated at 6 o'clock. 10 o'clock हो गया and patient अभी भी 6 centimeters dilated है in spite of good uterine contractions and in spite of the fact कि membranes ruptured है. So now my answer is going to be cesarean section. Clear to all of you? Okay. Have you understood when your answer is going to be oxytocin, when it is going to be ARM and when it is going to be cesarean section? Coming to the next question. A 23-year-old primigravida presents at 19 weeks of pregnancy. She has no significant medical history. Her family history is significant for diabetes running in the family. So she has family history of diabetes, right? Her ECG is normal and urine analysis is normal. Fasting blood sugar 126, HbAc 6.5. A patient is at 19 weeks of pregnancy and her fasting blood sugar is 126 and HbAc 6.5. She has diabetes running in the family. Please remember that जो gestational diabetes होती है, gestational diabetes किस time पे manifest करती है? Gestational diabetes manifest करती है at between 24 to 28 weeks of pregnancy. राइट उससे पहले अगर डायबिटीज हो रही है तो इट कुड बी अ केस ऑफ प्री जेस्टेशनल डायबिटीज. प्री जेस्टेशनल डायबिटीज की डायग्नोसिस के लिए वेरी वेरी इंपॉर्टेंट ये दोनों पॉइंट्स याद कर लो. फास्टिंग ब्लड शुगर मोर देन इक्वल टू 126, ये नॉर्मल डायबिटीज का क्राइटेरिया. यू ऑल नो दैट इन नॉन प्रेग्नेंट फीमेल्स मेल्स दैट इज हाउ यू कम टू नो कि फास्टिंग ब्लड शुगर मोर देन 126 एंड 2 RPP मोर देन इक्वल टू 200, HbAc मोर देन इक्वल टू 6.5. This means you are dealing with diabetes, and because this diabetes is happening at 19 weeks of pregnancy, हो सकता है कि ये पेशेंट को पता ही ना हो. प्री जेस्टेशनल डायबिटीज का मतलब है शी हैड डायबिटीज बिफोर प्रेगनेंसी. इस पेशेंट ने कभी भी टेस्ट नहीं कराया, इसलिए इसको पता ही नहीं था कि ये डायबिटिक है, एंड फॉर द फर्स्ट टाइम ये जाके डायग्नोज हो रही है ड्यूरिंग प्रेगनेंसी, बट शी इज नॉट अ केस ऑफ जेस्टेशनल डायबिटीज. जेस्टेशनल डायबिटीज डायग्नोज होती है बिटवीन 24 to 28 weeks. Right? Gestational diabetes के लिए I'm sure all of you know the DIPSI criteria. गवर्नमेंट ऑफ इंडिया सेज कि जेस्टेशनल डायबिटीज को डायग्नोज करने के लिए यू हैव टू डू द टेस्ट एट फर्स्ट एंटीनेटल विजिट एंड बिटवीन 24 to 28 वीक्स, irrespective of previous meals. जब भी आपके पास प्रेग्नेंट फीमेल आएगी एट फर्स्ट एंटीनेटल विजिट और बिटवीन 24 to 28 वीक्स, you are going to give her 75 grams of glucose in 300 ml of water. And then after 2 hours, you are going to check her blood sugar levels. If her blood sugar levels are less than 140, there is no diabetes. If it is between 140 to 199, it is a case of gestational diabetes. And if it is more than equal to 200, it is a case of pre-gestational diabetes. Right? Now, coming to the next question, question number 14. A 24-year-old female at 32 weeks of pregnancy, that means in third trimester, she is coming to you with BP 160 by 116. 160 by 116 का मतलब है she is a case of severe PIH. Right? And your question is saying that her liver enzymes are raised. So there are increased liver enzymes. And she has low platelet count. Now, whenever you have a case of severe PIH with increased liver enzymes and low platelet count, it means you are dealing with a case of HELP syndrome. राइट. अक्यूट फैटी लिवर ऑफ प्रेगनेंसी भी थर्ड ट्राइमेस्टर में प्रेजेंट करता है, लेकिन अक्यूट फैटी लिवर ऑफ प्रेगनेंसी में क्वेश्चन इज गोइंग टू से कि उसका KFT अब नॉर्मल है, बिकॉज इसमें देयर इज लिवर प्लस किडनी फेलियर. राइट, सो KFT अब नॉर्मल होगा, अमोनिया लेवल्स हाई कहेगा एंड क्रिएटिनिन लेवल्स हाई कहेगा, ग्लूकोज लेवल्स विल बी डिक्रीज्ड. So if you get a question जहां पे क्वेश्चन में अमोनिया लेवल्स हाई दिए हैं, KFT अब नॉर्मल दिया है, लिवर एंजाइम्स रेज्ड दिए हैं, ग्लूकोज लेवल्स डिक्रीज्ड दिए हैं, देन इट्स अ केस ऑफ अक्यूट फैटी लिवर ऑफ प्रेगनेंसी. कॉलीस्टैसिस में दे आर गोइंग टू से बाइल एसिड्स आर इंक्रीज्ड. So whenever your question says serum bile acids are increased, then that is cholestasis. Clear to all of you? Yes. What is the management of HELP syndrome? Management of HELP syndrome is immediate termination of pregnancy, and because इसमें severe PIH का complication होता है HELP syndrome, that is why you have to give magnesium sulfate ताकि patient को convulsions ना आए, and you have to give antihypertensive. So you have to give her antihypertensive, you have to give her magnesium sulfate so that she doesn't throw any convulsions, and you have to go for immediate termination of pregnancy. Clear? Which of the following curve or peak is responsible for ovulation? So over here we are seeing this is ovulation, right? And we are seeing that over here. Now tell me, which peak do you think is responsible for ovulation? Now this peak over here is responsible for ovulation. That means peak C is responsible for ovulation. Which is the hormone which comes in peak C? It is LH. It is LH surge which is responsible for ovulation. Please remember, ovulation के लिए responsible होता है LH surge, but before ovulation there is both LH and FSH surge. That is why you are getting FSH levels also high over here. Right? So before ovulation there is both LH and FSH surge, but the one which is responsible for ovulation is LH surge, that is peak C. Now what do you think is this hormone which is increasing after ovulation? Which hormone increases after ovulation? Progesterone. So peak D is representing progesterone. And which hormone increases before ovulation? Estrogen. So your peak A is estrogen. Clear to all of you? Next very important question is, what is the time difference between LH surge and ovulation? Best answer is 32 to 36 hours. Second best answer is 24 to 36 hours, right? What is the time gap between LH surge and ovulation? 32 to 36 hours. Why does LH surge happen? LH surge happens due to increase in estrogen. ये increased estrogen की वजह से LH surge हुआ. Now, if they ask you what is the time gap between LH surge and ovulation, it is 32 to 36 hours. But if they ask you what is the time gap between LH peak and ovulation, it is 10 to 12 hours. Clear to all of you? What is the first sign of ovulation on endometrial biopsy? The first sign of ovulation on endometrial biopsy is subnuclear vacuolation. Clear to all of you? Next question, identify the fibroid marked with X. So over here I have not marked with X. You are just going to tell me what fibroid you are seeing over here. Now a fibroid which is coming totally inside the uterine cavity is a submucous fibroid. In this case, the fibroid is coming inside the uterine cavity, but it is inside the myometrium also. So this is also a variety of submucous fibroid. This fibroid is totally in the peritoneal cavity. So this is subserous fibroid. And this fibroid is totally inside the myometrium. So this is intramural fibroid. A fibroid which is totally inside the myometrium is intramural or interstitial fibroid. Clear to all of you? Okay. Now, remember a very important thing. FIGO has said that there are 3 types of submucous fibroid. Type 0, type 1 and type 2. Type 0 submucous fibroid is a fibroid which is totally inside the uterine cavity. So this fibroid which was totally inside the uterine cavity was type 0 submucous fibroid. Then type 1 का मतलब होता है more than 50% fibroid is inside the cavity, less than 50% is inside myometrium. Type 2 का मतलब होता है more than 50% is in the myometrium, less than 50% is in the cavity. So over here, if you look at this fibroid, in this fibroid, less than 50% is inside the cavity, more than 50% is inside myometrium. Since more than 50% is inside the myometrium, that is why I'm going to call it as a type 2 submucous fibroid. Now, why was this classification given? You just have to remember that type 0 and type 1 can be removed by hysteroscope. Type 2 cannot be removed by hysteroscope. It cannot be removed hysteroscopically. That is what you have to remember. Type 0, type 1, type 2. Have you understood? Okay. Coming to the next question. Identify the swelling which is seen in 22-year-old female. So this swelling, and many times question has been asked on this. This swelling which you are seeing over here is between labia majora and labia minora, and it is posterolateral swelling. Please remember, there are 3 types of cysts जिसपे questions आ सकते हैं. Most common cyst which you get in vagina is inclusion cyst. Now, if you are getting a cyst between labia majora and minora or inside the vestibule and it is posterolateral, do you see over here? This swelling over here is on the posterior side and on the lateral side. Posterolateral अगर cyst मिल रही है, that's a Bartholin cyst. अगर कोई भी cyst anterolaterally मिल रही है and vagina की wall में मिल रही है, then that's a Gartner's cyst. Please do not get confused between Bartholin cyst and Gartner's cyst. Look over here. This blue color cyst is posterolateral, right? So this will be Bartholin cyst. This red color cyst is anterolateral. So this will be Gartner's cyst. Number 1. Number 2, do you see this green color marking over here? ये जो ग्रीन कलर की सिस्ट है ये ब्लैडर के यूरिथ्रा के पास मिल रही है, राइट? सो ये जो सिस्ट होती है इसको कहते हैं पैरायूरिथ्रल सिस्ट, राइट? सो ओवर हियर this green color is near the urethra, so this is paraurethral cyst. ये जो cyst है ये posteriolateral है, so this is Bartholin cyst. अब गार्टनर सिस्ट कहां मिलेगी? गार्टनर सिस्ट मिलेगी एंटीरोलेटरल, एंटीरोलेटरल होती तो गार्टनर्स सिस्ट, राइट? कभी समटाइम्स दे गिव यू अ स्पॉट इमेज and they ask you what is it, and you get confused between Gartner's cyst and cystocele. So this over here is image A and this is image B. इस इमेज A में पहले ये बताओ कहां पे मिल रही है सिस्ट? क्या ये सिस्ट यूरिथ्रा के पास है? नहीं, this is not near the urethra, so it cannot be a paraurethral cyst. Can you see the marking of urethra? It is not near the urethra. ये जो cyst है ये anteriorly मिल रही है, so ये Gartner's cyst हो सकती है या ये cystocele हो सकता है, जैसे कि यहां पे। अब Gartner's cyst and cystocele में कैसे डिफरेंशिएट करोगे? Gartner's cyst स्मूथ होगा, सिस्टोसील में ऐसे विजाइना में जैसे रुगोसिटीज मिलती हैं वैसे सिस्टोसील में भी हमें रुगोसिटीज मिलेंगी। डू यू सी दीज रुगोसिटीज ओवर हियर? तो अगर आपको रुगोसिटीज मिल रही हैं तो इट मींस इट्स अ सिस्टोसील। अगर आपको बिल्कुल स्मूथ सिस्ट मिल रही है एंटीरियर वॉल में, दैट मींस इट इज गार्टनर्स सिस्ट, राइट? सो लुक ओवर हियर, ये जो सिस्ट है ये हमें कहां मिल रही है इन योर क्वेश्चन? इन द क्वेश्चन द सिस्ट इज हैपनिंग इन द पोस्टीरोलेटरल side and it is between labia majora and minora, so this is a Bartholin cyst. Clear to all of you? Okay. Now just one quick thing about Bartholin cyst ka management. If you are a Maro subscriber, you already know this. Asymptomatic Bartholin cyst which is less than 3 centimeters, it doesn't need any treatment. Asymptomatic cysts which are more than 3 centimeters, पहले हम कहते थे कि Bartholin cyst का मैनेजमेंट इज मार्सुपिलाइजेशन, अब नहीं है मार्सुपिलाइजेशन। Bartholin cyst अगर वो एसिम्प्टोमेटिक है उसका मैनेजमेंट है इंसिशन एंड ड्रेनेज। Bartholin abscess का भी मैनेजमेंट है इंसिशन एंड ड्रेनेज। Only if your question says recurrent Bartholin cyst, the management is marsupilization, right? So management of Bartholin cyst is not marsupilization now. Management of Bartholin cyst now is incision and drainage, IND. Clear? Okay. Next question. The most effective cost-effective cervical cancer screening test is? Please remember, the most cost-effective test is VIA. What is VIA? Visual inspection with acetic acid. Visual inspection with acetic acid, ये जो हम करते हैं, this is done with 3 to 5% acetic acid. And जब हम acetic acid अप्लाई करते हैं तो जो नॉर्मल एरियाज होते हैं वो पिंक रहते हैं and जो abnormal एरियाज होते हैं, if you see these abnormal areas will start appearing white in color. So जब भी हम एसिटिक एसिड अप्लाई करते हैं पेशेंट की सर्विक्स पे तो वो एरियाज where dysplasia is present, it will appear white in color, and the areas where dysplasia is not present, it is going to appear pink in color. So the most cost-effective cervical cancer screening method is VIA. Now, new WHO guidelines, if you are a Maro subscriber, you already know them. Quickly revise with me. According to WHO, the screening for cancer cervix should begin at 30 years. You should stop the screening at 49 years. And the best method for screening is HPV plus VIA. If HPV plus VIA is not given, then the second best method is HPV and the third best method is only VIA. Right? Best is HPV plus VIA. वो नहीं है तो only HPV, वो नहीं है तो only VIA. Pap smear is not recommended by WHO for screening of cancer cervix. Most sensitive method for screening of cancer cervix is HPV DNA testing. Most specific method is Pap smear testing. WHO कहता है कि why Pap smear should not be done in developing countries like India is क्योंकि based on Pap smear report we can never do the treatment for CIN or for cancer cervix. अगर हम Pap smear करते हैं and if anything abnormal report comes, then you always have to do colposcopy and biopsy. So Pap smear should always be followed by colposcopy and biopsy. Someone is asking me what is meant by marsupilization. Marsupilization का मतलब है you are removing the cyst and the side walls are stitched to the surrounding skin, right, so that a cyst formation doesn't happen again. Right, so remove the cyst and the side walls are stitched to the surrounding skin. You don't need to know what is marsupilization. You just need to know that the treatment of choice for Bartholin cyst these days is IND. Only for recurrent Bartholin cyst we do marsupilization. Right? Coming to this, very very important. So Pap smear के basis पे we never do, or based on Pap smear we are never going to do management. Pap smear should always be followed by colposcopy and biopsy. Right? Now suppose colposcopy report comes as CIN1. What is the management of CIN1? Management of CIN1 is follow up for 2 years. And if CIN1 persists even after 2 years, then you do cryoablation. Management of CIN2 and CIN3 is LEEP, LLETZ or LEEP. LEEP is loop electroexcisional procedure. LLETZ is large loop excision of transformation zone. जब भी question कहे what is the management of CIN2 or CIN3, please do not say it is hysterectomy. Management of CIN2 and CIN3 is LEEP or LLETZ. Right? अब cancer cervix का management. Cancer cervix up till stage 2A. Management is surgery, right? So for up till stage 2A of 2A1 of cancer cervix, management is surgery. इसमें एक exception होता है stage 1B3. Stage 1B3 में surgery नहीं करते, but other than that up till stage 2A1 management is surgery. From stage 2A2 onwards, 2A2 के बाद चाहे वो stage 2B हो, चाहे वो 3 हो, चाहे वो 4 हो, always management is chemo radiation. अगर options में chemo radiation नहीं दिया है, then you are going to mark the answer as radiotherapy. Stage 1B3 maybe chemo radiation is the answer. So very simple, you are going to remember. CIN1 का management होता है follow up for 2 years. Right? And 2 years के बाद if it persists, cryoablation. CIN2 and CIN3 का management is LEEP or LLETZ. Cancer cervix का management बस इतना याद रखो, cancer cervix में up till stage 2A1 surgery करते हैं, but 1B3 में surgery नहीं करते. In stage 1B3 and any stage after 2A2, management is chemo radiation. Clear to all of you? Okay. Now, because a question has come in your recent FMGE exam, that is why I taught you this much detail. Now, which of the following has a false positive bar body? First, tell me bar body is number of X chromosomes minus 1. Right? So, Turner's syndrome में there is no bar body. Right? Trisomy 21. Trisomy 21 में extra 21 chromosome होता है. It has nothing to do with X or Y. Klinefelter's syndrome में there will be one bar body. And androgen insensitivity syndrome, which is 46XY, there will be no bar body. Now, why are they saying false positive bar body? False positive bar body इसलिए कह रहे हैं because generally जो females होती हैं उनमें bar body present होती है because females are 46XX and males are 46XY, so bar body is absent in males. राइट, मेल फीमेल कैसे डिसाइड होता है? मेल फीमेल डिसाइड होता है बाय प्रेजेंस और एब्सेंस ऑफ वाई क्रोमोसोम. वाई क्रोमोसोम प्रेजेंट है तो मेल है, वाई क्रोमोसोम एब्सेंट है तो फीमेल है. तो टर्नर सिंड्रोम में वाई क्रोमोसोम एब्सेंट होता है, दैट इज वाई टर्नर सिंड्रोम आर फीमेल्स. लेकिन ये टर्नर सिंड्रोम में फीमेल होने के बाद भी देयर इज नो बार बॉडी, राइट? Whereas Klinefelter syndrome में Y chromosome is present, that means they are males. And even though they are males, still they have one bar body. That is what is false positive bar body, right? So Klinefelter syndrome has false positive bar body. Klinefelter syndrome in the past 3 sessions 2 बार पूछा गया है. एक ये क्वेश्चन पूछा गया है false positive bar body, and abhi ek aur question aayega on Klinefelter syndrome. So Klinefelter syndrome is very very important for all of you. Next question. A mother brings her 18-year-old daughter to Gyne OPD with complaint of not attained menarche, right? Hormonal study shows normal LH FSH. Ab your question, I am just asking you, if हार्मोनल स्टडीज आर शोइंग नॉर्मल LH FSH, इसका क्या मतलब हुआ? इसका मतलब है कि हाइपोथैलेमस नॉर्मल है एंड हाइपोथैलेमस GnRH नॉर्मली रिलीज कर रहा है, जिसकी वजह से पिट्यूटरी भी नॉर्मली FSH LH रिलीज कर रहा है. सो द मोमेंट योर क्वेश्चन सेज नॉर्मल LH FSH, आई नो कि कोई प्रॉब्लम हाइपोथैलेमस में नहीं है, कोई प्रॉब्लम पिट्यूटरी में नहीं है. Right? Now your question is saying normal breast development and pubic hair development. Breast development के लिए the hormone which is responsible is estrogen. Right? So if normal breast development है तो इसका मतलब है कि ovary भी normal है. Because ovary normal है, that is why estrogen normal है, that is why breast development is normal. Right? Now your question further says ultrasound shows small blind vagina. Ultrasound is showing small blind vagina and absent uterus. Karyotype is 46XX. Karyotype, if it is 46XX and there is no uterus, what does that mean? It is a case of Mullerian agenesis. In androgen insensitivity syndrome, the karyotype is 46XY. In Turner syndrome, karyotype is 46XO, and Turner syndrome में ovaries are streak ovaries. They are not functioning normally. And because ovaries don't function normally, that is why in Turner syndrome estrogen is less, and that is why breast development is absent. So this cannot be a case of Turner syndrome, this cannot be a case of androgen insensitivity syndrome, it is a case of Mullerian agenesis. Please remember, androgen insensitivity syndrome की एक बहुत खास बात होती है. Whenever your question says that there is absent uterus, breast development is present, but pubic hair is less या scanty, then it means it is androgen insensitivity syndrome. क्योंकि hormone responsible for pubic hair in females is androgen. Right? Breast development के लिए hormone responsible is estrogen. Pubic hair के लिए hormone responsible is androgen. So now you can ask me कि मैम breast क्यों develop होता है androgen insensitivity syndrome के patients में? Because the androgens get converted into estrogen and these individuals respond to estrogen. They are insensitive to androgen. So इनके अंदर breast development होता है लेकिन pubic hair development is not there. Clear? Next question. A 26-year-old female attends Gyne OPD with complaint of secondary amenorrhea. She has history of previous DNC and her FSH levels are 6 international units. The probable cause of amenorrhea is. Now, iske baad jo I am going to tell you, you are going to take a screenshot and keep it with you. These days, they are asking questions based on FSH levels. Right, so I am going to tell you how you are going to approach questions based on FSH levels. Please remember, normal FSH levels are up till 10 international units. If your question says that FSH levels are 1 to 2, yeah, 2 to 3, that means FSH levels are in low normal. So, अगर FSH levels low हैं, that means problem या तो hypothalamus में है या pituitary में है. Hypothalamus की problem क्या हो सकती है? Kallmann syndrome. Kallmann syndrome में you get anosmia. So question में anosmia भी दिया होगा. So levels of FSH will be less. Patient will come to you with amenorrhea and there will be anosmia. अब अगर पिट्यूटरी की प्रॉब्लम है देन ऑल्सो लेवल्स ऑफ एफएसएच विल बी लेस. पिट्यूटरी की प्रॉब्लम कैन बी शी-हैन सिंड्रोम. इन शी-हैन सिंड्रोम पेशेंट विल कंप्लेन ऑफ फेलियर टू लैक्टेट. तो लाइन अगर दी है कि एमेनोरिया है, फेलियर टू लैक्टेट है एंड एफएसएच लेवल्स कम है, इट मींस शी-हैन सिंड्रोम. और इट कुड बी अ केस ऑफ प्रोलैक्टिनोमा. Prolactinoma के केस में they are going to give you headache and visual symptoms. So if your question says that there is amenorrhea plus there is FSH levels are low and there is headache and visual symptoms, it means prolactinoma. There is one more case जिसमें FSH levels will be low and amenorrhea होगा, that is pregnancy. Pregnancy में भी FSH levels less होते हैं and you get amenorrhea. Right? Why FSH levels are less in pregnancy? Because in pregnancy the levels of estrogen are high and estrogen has a negative feedback on FSH. Clear? Now, second case ये हो सकता है कि your question is saying that the levels of FSH are high, more than 20. Now, whenever your question says levels of FSH are high and your patient is having amenorrhea, इसका मतलब problem ovary में है. Why? Because just now I told you estrogen has a negative feedback on FSH. So अगर problem ovary में होगी, the levels of estrogen will be less, so the negative feedback on FSH will be lost and the levels of FSH will increase. So whenever you get a question जिसमें ये कहा हो कि FSH levels high हैं and amenorrhea है, तो problem is in the ovaries, right? तो primary amenorrhea में problem ovary में क्या हो सकती है? Turner's syndrome. Secondary amenorrhea का केस है तो क्या problem हो सकती है? Premature menopause, right? Now if your question comes कि FSH levels normal हैं and your patient is having amenorrhea, so number one you have to think कि problem uterus में है, right? So problem is in the uterus. Problem ना तो hypothalamus में है, ना pituitary में है, ना ovary में है. So uterus की problem which leads to secondary amenorrhea is Asherman syndrome. Uterus की problem which leads to primary amenorrhea is Mullerian agenesis and androgen insensitivity syndrome. Mullerian agenesis में 46XX दिया होगा, androgen insensitivity में 46XY दिया होगा. Another reason which can lead to FSH normal and amenorrhea is PCOS. Please remember, PCOS के patients में FSH levels are normal, LH levels are high, and they can present to you as a case of amenorrhea. So if you remember this chart, इस चार्ट का आई वॉन्ट ऑल ऑफ यू टू टेक अ स्क्रीनशॉट. If you remember this, your questions on amenorrhea will never be wrong, right? Uh, can you people hear me? Okay. Now, so in this case, they are saying FSH levels are 6 international units. That means FSH levels are normal. Normal FSH levels किसमें मिलते हैं? That means problem किसमें है? Uterus में है. And patient आ रहा है secondary amenorrhea के साथ. So that means she is a case of Asherman syndrome. राइट. शी-हैन सिंड्रोम में एफएसएच लेवल्स हमें डिक्रीज्ड मिलते, प्रेगनेंसी में एफएसएच लेवल्स हमें डिक्रीज्ड मिलते, प्री मेच्योर ओवेरियन फेलियर दैट इज प्री मेच्योर मेनोपॉज में एफएसएच लेवल्स इंक्रीज्ड मिलते. क्लियर? नेक्स्ट क्वेश्चन. A 16-year-old female visits Gyne OPD with complaint of cyclical pain in abdomen and no menarche. On examination, breast development is normal, pubic hair is normal. Local examination shows bulging bluish hymen. And on per rectal examination, uterus is present. तो जैसे ही क्वेश्चन ये कहे कि पेशेंट साइक्लिकल पेन इन abdomen के साथ आया है and there is a bulging bluish hymen, that means we are dealing with imperforate hymen, and management of imperforate hymen is you have to give a cruciate incision on the hymen. Next question. A 55-year-old post-menopausal female attends OBGY clinic and she has history of chronic pelvic pain. X-ray shows the following. अब X-ray में हमें क्या दिख रहा है? Calcification दिख रहा है and a huge calcification is seen. Right? You have to tell me whether it is ovarian mass, PID, calcified fibroid or bladder stone. Please remember कि ओवेरियन मास जिसमें कैल्सिफिकेशन मिलता है दैट इज अ डर्मोइड सिस्ट. डर्मोइड सिस्ट में यू कैन गेट कैल्सिफिकेशन, बट डर्मोइड सिस्ट इज सीन इन यंग फीमेल्स. यहां पे हमें एज दिया है 55-year-old पोस्ट मेनोपॉजल फीमेल, राइट. एंड डर्मोइड सिस्ट में जनरली यू गेट अ कैल्सिफाइड टूथ या हमें रॉकेटेंस की प्रोट्यूबरेंस मिलेगा कैल्सिफाइड. यू विल नॉट गेट अ बिग कैल्सिफिकेशन लाइक दिस, राइट. सो ओवेरियन मास रूल्ड आउट. ब्लैडर स्टोन, पेशेंट इज नॉट कमिंग टू यू विद एनी यूरिनरी सिम्टम्स. इतना बड़ा ब्लैडर स्टोन without urinary symptoms ho, it is not possible. And bladder stone will be centrally located. This mass which you are seeing is eccentrically located. So this is most probably a calcified fibroid, right? Now fibroid में जब भी calcification होता है, that is, it gives the appearance of a popcorn calcification. So over here you are getting a popcorn calcification like picture, and the most common fibroid which leads to popcorn calcification is subserosal fibroid, right? Next question. A female after delivery complains of cramps during breastfeeding. Which hormone is responsible for it? Please remember that for milk production, the hormone which is responsible is prolactin. And for milk ejection, the hormone which is responsible is oxytocin. Oxytocin also leads to uterine contractions. That is why whenever there are cramps which are felt during breastfeeding, it is due to the hormone oxytocin, because oxytocin is leading to uterine contractions as well, right? Next question. A 25-year-old female and her husband present to infertility clinic. Semen analysis is normal, but HSG shows distal dilatation of the tube. On taking proper history, female complains of menorrhagia. The most likely cause of infertility is. Now, this is how distal dilatation appears, right? Now remember that distal dilatation अगर हमें मिल रहा है, that means the fimbrial end of the tube is blocked, and ये fimbrial end can be blocked in case of TB and in case of salpingitis. Which salpingitis? Gonorrhea, राइट. सो गोनोरिया की वजह से हमको डिस्टल एंड का ब्लॉकेज मिल सकता है. नाउ व्हेनेवर यू आर गेटिंग प्रॉक्सिमल ब्लॉक, ये देख रहे हो, दिस इज प्रॉक्सिमल ब्लॉक, डाई यहां से आगे जा ही नहीं रही है. सो दिस इज व्हाट इज कॉल्ड एज कॉर्नुअल ब्लॉक और प्रॉक्सिमल ब्लॉक. मोस्ट कॉमन कॉज ऑफ अ कॉर्नुअल ब्लॉक और proximal block is physiological spasm. Tube में spasm हो जाता है. That is the most common cause. Very, very important question. So if they show you this HSG day after tomorrow and they ask you what is the most common cause, please do not say TB. Most common cause is physiological block. Right? But which pathology leads to corneal block? TB. इसका मतलब TB से proximal block भी हो सकता है, TB से distal block भी हो सकता है. Generally TB से proximal block होता है, but then distal block can also happen with TB. So now how am I going to decide whether she is a case of genital tuberculosis or whether she is a case of salpingitis? Spasm की वजह से cornual block मिलता, right? Now comes this, that the female gives complaints of menorrhagia. टीबी के पेशेंट में जो मोस्ट कॉमन कंप्लेन मिलती है दैट इज एमेनोरिया. अ पेशेंट ऑफ टीबी इज गोइंग टू कम टू यू विद एमेनोरिया, राइट. मेनोरेजिया की कंप्लेन मिलती है सैल्पिंजाइटिस में. So over here answer is going to be salpingitis. Why it is not a polyp? Because if this would have been polyp और जब हम डाई पास करते तो हमें एक फिलिंग डिफेक्ट मिलता, राइट. सो क्योंकि क्वेश्चन इज नॉट सेइंग अबाउट फिलिंग डिफेक्ट, दैट इज व्हाई इट इज नॉट अ पॉलिप, राइट. नाउ विच डाई इज यूज्ड फॉर HSG, ये क्वेश्चन आया हुआ है, एंड द डाई विच इज यूज्ड फॉर HSG इज मिथिलीन ब्लू यूरोग्राफिन. यूरोग्राफिन इज द डाई विच इज यूज्ड फॉर HSG. Next, a 55, this is the question which I was talking about. A 55-year-old female is found to have cervical cancer stage 3B. What is the management? Now you tell me. 3B, matlab this is stage 3. And I told you 2A2 के beyond, 2A2 plus इसके beyond, हम हमेशा कीमो रेडिएशन करते हैं. Right? So your answer is concurrent chemo radiation. Clear to all of you? So whenever it is stage 2A2 and beyond that, you always do chemo radiation. That is something which I told you just now. So your answer is going to be chemo radiation. Clear? That completes your FMGE June 2021 paper. Coming to December 2021 paper. According to MTP Act 2021 guidelines, MTP can be done up till how many weeks? So up till how many weeks can you do MTP? MTP can now be done up till 24 weeks. But if pregnancy is due to contraceptive failure, then you can do it still only up till 20 weeks. Right? And in case of severe fetal anomalies, there is no upper limit. 3 things you have to remember. अब हम MTP कर सकते हैं अप टिल 24 वीक्स, बट अगर कॉन्ट्रासेप्टिव फेलियर की वजह से है तो स्टिल अप टिल 20 वीक्स, एंड इन केस ऑफ सिवियर कंजेनिटल अनोमली देयर इज नो अपर लिमिट. नेक्स्ट क्वेश्चन. A G3P2 lady presents at 8 weeks of pregnancy for MTP. 8 weeks of pregnancy में just now I told you कि up till 7 weeks हम क्या करेंगे? Medical abortion. 7 to 12 वीक्स में हम क्या करेंगे? सक्शन इवैक्यूएशन. सक्शन इवैक्यूएशन कैसे करते हैं? आई टोल्ड यू सक्शन इवैक्यूएशन के लिए यू आर यूजिंग अ Karman's cannula. This is how a Karman's cannula appears like, and this has to be attached to a suction machine, right? So the number on Karman's cannula, it corresponds to the diameter of the cannula in millimeters, and the size of the cannula is equal to the duration of pregnancy in weeks. जितने weeks की pregnancy है उतना size Karman's cannula you are going to use, right? So if this is 8 weeks pregnancy, I am going to use 8 number cannula. Now suppose in your options you are given 5, 7, 9 and 11, and patient is 8 weeks pregnant. Now what are you going to mark the answer as? So the best answer is that the number on the cannula should correspond to the weeks of gestation. But if option में ये नहीं दिया है, then you have to choose one less. That means if it is 8 weeks, you are going to choose 7 number cannula. You are not going to choose 9 number cannula. Right? So either it has to correspond to the gestation or one less. Clear? Okay. So everything about manual vacuum aspiration and menstrual regulation I've already told you. Now next question. A patient presents with 45 days of amenorrhea. She wants abortion. If you are a treating doctor, what would you prefer? 45 days of amenorrhea का मतलब है that she is 6 weeks pregnant, right? And up till 7 weeks. That means up till 49 days, we go for medical abortion. So in India, medical abortion is done up till 7 weeks. WHO says that medical abortion can be done up till 9 weeks, right? Now, when you are doing medical abortion up till 7 weeks, it is done as an OPD procedure. But when you are doing it between 7 to 9 weeks, you have to admit the patient and then do it. What is the protocol? On day 1, you are going to give 200 milligrams of oral mifepristone. And then on day 3, you are going to give misoprost. How much misoprost? 400 micrograms of misoprost, right? It has to be given on day 3. Then in case you are doing abortion between 7 to 9 weeks, so day 1 same रहता है. You have to give 200 milligrams of mifepristone, but now the misoprost which you have to give is 800 micrograms, right? So up till 7 weeks हम 400 micrograms देते हैं. After that हम 800 micrograms देते हैं. And then after 2 weeks, we call the patient for follow-up to see whether the whether the process of abortion is complete or not, right? So now over here, 45 days pe patient has come to you. So you are going to give 200 milligrams of mifepristone and 400 micrograms of misoprost after 48 hours. Clear to all of you? Yes? Right, Pushpa, if in questions they don't mention the gestational age, then they are going to give you 800 micrograms of misoprost, mark it as 800 because 400 to 800 के बीच में हम कुछ भी दे सकते हैं. Right, so even if the gestation age is not given and they have given 800 micrograms of misoprost, mark the answer as 800 micrograms of misoprost. Right? Okay. Maximum amount of amniotic fluid is seen as, please remember, maximum amount of amniotic fluid कब देखने को मिलता है? 34 weeks पे. And range क्या होती है? 32 to 34 weeks. Right? So maximum amount is at 34 weeks. Range is 32 to 34 weeks. So in your question which came, you are going to mark the answer as 32 weeks here. Clear? Now, so this is a very theoretical type of a thing कि 32 to 34 weeks के बीच में amount is 1 liter, 36 weeks पे 900 ml, at term it is 800 ml, and after that जैसे जैसे pregnancy बढ़ेगी वैसे वैसे the amniotic fluid will decrease. So at 42 weeks it is 200 ml. Nothing to mug up here. You just need to remember when is the amniotic fluid maximum? 34 weeks. Range is 32 to 34 weeks. Identify the ultrasound which is given in the uterus, ultrasound of the uterus. What is being shown over here? You are seeing snowstorm appearance, and snowstorm appearance, if you are getting on ultrasound, that means this is a case of complete mole. What is the other name for complete mole? The other name for complete mole is vesicular mole or high datiform mole. In case of complete mole, you get a snowstorm appearance, which is also called as honeycomb appearance. What is the karyotype for a complete mole? The karyotype for a complete mole is 46XX. That's the most common karyotype. Complete mole is diploid. Please remember, complete mole mein there is an empty ova which is being fertilized by a sperm, and then the chromosome number of the sperm duplicates, so they are diploid. Most common chromosome number is 46XX, and in case of complete mole you don't see any fetal part, whereas partial mole mein jo karyotype hota hai, they are triploid, and you get 69XXY. That is the most common chromosome number. Partial mole mein some part of the fetus will be seen on ultrasound, and that is why it resembles incomplete abortion. So if you are getting a snowstorm appearance on ultrasound, that means you are dealing with a complete mole, or which is also called as vesicular mole. If you are getting snowstorm appearance on chest x-ray, that means it is a choriocarcinoma which has metastasized to the lungs. If they ask you what is the most common appearance of a choriocarcinoma on chest x-ray, then that is not snowstorm appearance. Most common appearance is cannonball appearance. In which stage of choriocarcinoma you get lung metastasis? In stage 3 you get lung metastasis. Clear? Clear to all of you? So this is a case of high datiform mole. High datiform mole का मतलब ही होता है complete mole और vesicular mole, right? Okay. Then, which of the following is an indication for surgical management of ectopic pregnancy? So remember, ectopic pregnancy जब भी हमारे पास ruptured ectopic pregnancy होती है, ruptured ectopic pregnancy में you always have to do surgical management, right? And the surgery which you have to do in ruptured ectopic is salpingectomy, whether the family of the patient is complete or not. एक ही surgery करते हैं if there is ruptured ectopic, and that is salpingectomy. You have to remove the ruptured tube. Now, in case of unruptured ectopic, you have the option of doing medical management, or you can go for surgical management. Now, medical management, we do it in unruptured ectopic. You never do medical management in ruptured ectopic. And how do I come to know it is unruptured? Because vitals of the patient will be stable. So only if vitals of the patient are stable, if free fluid is less than 100 cc, then I am going to do medical management, right? This is an absolute requirement कि patient के vitals should be stable. It should be a case of unruptured ectopic, and the free fluid should be less than 100 cc. Other than that, HCG value should be less than 5000. Size of the ectopic should be less than 4 centimeters. Cardiac activity should be absent, and there should be absent or minimal pain. These are requirements, relative requirements for medical management. Now suppose your question says cardiac activity present hai. Cardiac activity present hai, so it doesn't mean कि medical management is contraindicated. But medical management is not preferred if cardiac activity is present. Right? We don't prefer medical management. We prefer surgical management if cardiac activity is present. Clear to all of you? Yes? Beta HCG less than 5000. Clear? What you are saying, beta HCG less than 1000, that's not right. Beta HCG less than 5000. Now, which of the following is an indication for surgical management? Size of the ectopic more than 4 centimeters. So, if size of the ectopic is more than 4 centimeters, I prefer surgical management. Less than 4 centimeters hota hai, then I go for medical management. Beta HCG less than 1000. Ab beta HCG less than 1000 hai, so obviously medical management. Patient wants to continue pregnancy. This is a very faltu option which they have given. Unruptured ectopic mein medical management. So the answer over here is option A. If size of the ectopic is more than 4 centimeters, then you have to go for surgical management. So I am repeating. Someone asked me to repeat. Just quickly I am telling you. Medical management ki requirements kya hoti hai? It is done in case of unruptured ectopic. Number 1. It is done only if vitals of your patient are stable. It is done only if free fluid is less than 100 cc. These are three absolute requirements for medical management. अब इसके अलावा HCG levels should be less than 5000, size of the ectopic should be less than 4 centimeters, cardiac activity should be absent, and there should be no pain. Now, as far as cardiac activity is concerned, cardiac activity is a relative requirement. अगर cardiac activity present है and your patient says that I want to get a medical management done, you may do a medical management, लेकिन हम prefer surgical करते हैं. Why हम medical prefer नहीं करते? Because of the chances of failure of medical management. If cardiac activity is present, there are high chances of failure of medical management. So this is the criteria or absolute requirement for medical management. These are relative requirements for medical management. Ruptured ectopic में always and always surgery has to be done, right? Cardiac output returns to normal by, so remember, after delivery, cardiac output returns to normal by 10 days after delivery, right? Another very important thing which you have to remember is, when is cardiac output maximum? So cardiac output is maximum immediately after delivery, right? So the chances of heart failure are maximum immediately after delivery, then in the second stage of labor, then in late first stage of labor, and then between 28 to 32 weeks of pregnancy, right? So maximum cardiac output is immediately after delivery, then second stage of labor, then late first stage of labor, and then between 28 to 32 weeks, right? Cardiac output returns to normal by 10 days after delivery. Blood volume returns to normal by 1 week after delivery. Clear? Absolute contraindication to breastfeeding. Please remember, there is only one infection जो कि absolute contraindication होता है to breastfeeding, and that is herpes simplex infection, and that too if it is present on the breast area. That is an absolute contraindication to breastfeeding. इसके अलावा कोई भी infection is not an absolute contraindication to breastfeeding, right? Absolute contraindication to breastfeedings are if the female is IV drug abuser, or if she uses excessive alcohol, if she is on anti-cancer drugs, if she has herpes simplex infection on the breast, if the baby has lactose intolerance or baby has galactosemia, right? As far as untreated pulmonary tuberculosis is concerned, and as far as HIV is concerned, in developing countries, they are not a contraindication, right? And iske alawa to koi bhi infection is not a contraindication, whether it is developing country, whether it is developed country. Hepatitis C, hepatitis B, HPV, COVID, torch test, none of them is a contraindication to breastfeeding, right? Developed countries में pulmonary tuberculosis untreated and HIV is a contraindication, but developing countries में वो भी contraindication नहीं है. That's not a contraindication, right? If the patient is on warfarin, that's not a contraindication, right? Warfarin is very safe during lactation. So over here the answer is galactosemia. Clear to all of you? Then hormone responsible for pain during breastfeeding, just now we did, it is oxytocin. How much is the recommended dose of folic acid in pregnancy with previous history of neural tube defect? So all of you know that if there is previous history of neural tube defect, you have to give 4 milligrams of folic acid. Otherwise, it is 400 micrograms. Normally, in all females, the dose of folic acid which you have to give to prevent neural tube defects is 400 micrograms. But if there is previous history, you have to give 4 milligrams. If a female is on anti-epileptic drugs, then also the dose which you have to give is 4 milligrams. Then, if a patient is diabetic, right, then the dose which you have to give is 400 micrograms. Don't say it is 4 milligrams, right? Diabetic patients, maybe the dose of folic acid is 400 micrograms. What is the dose of folic acid in red pill? right? So जो red pill government of India देती है to prevent anemia, what is the dose of folic acid? 500 micrograms. Clear to all of you? Yes. Till how long do you have to give folic acid? Folic acid should be started 1 month before pregnancy and it should be continued for 3 months after pregnancy. From 4th month onwards, we will give red pill. And ये जो red pill होता है, इसमें कितना iron होता है? It has got 60 milligrams of iron and 500 micrograms of folic acid, right? And it should be continued throughout pregnancy and 180 days after delivery. Clear? Okay. Next question. Minimum number of antenatal visits as recommended by WHO. WHO की new recommendations are 8 antenatal visits. According to Government of India, there are 4 antenatal visits, right? Then which of the following is the safest drug to be used for pregnancy induced hypertension? The safest drug which can be used for pregnancy induced hypertension is methyl dopa. Please remember that now they say there is no drug of choice for PIH. Now they say PIH ke liye there are 3 first line drugs. What are the first line drugs for PIH? The first line drugs for PIH are number 1, labetalol, number 2, hydralazine, and number 3, nifedipine. So labetalol, hydralazine and nifedipine, they are first line drugs for treating severe PIH. Please remember these antihypertensives you are going to use only in severe PIH. That means once BP is more than 160 by 110, then only you have to use antihypertensives, right? For mild PIH, antihypertensives role is not there. You do not use antihypertensives for mild PIH. Clear to all of you? Okay. What are the antihypertensives which are contraindicated in pregnancy? So ACE inhibitors, angiotensin receptor blockers, diazoxide, diuretics and beta blockers. These are antihypertensives which are contraindicated in pregnancy. Diuretic is contraindicated as an antihypertensive. But if your pregnant female has heart disease, that is heart failure, if your pregnant female gets heart failure, then you can use diuretic. As antihypertensive, it is contraindicated. Right? Why answer is not hydralazine? See, hydralazine is not the answer. Answer is methyl dopa. That is what we that's how the studies have shown. Methyl dopa is one of the safest drug to be used in pregnancy as antihypertensive. Right? Okay. Then a patient presents with positive urine pregnancy test. In which of the following conditions you will have to assess the pregnancy test repeatedly? So rather than saying HCG levels repeatedly, they are saying pregnancy test repeatedly. So all of you know that if it is a case of molar pregnancy may after evacuation, you have to do HCG levels up till 6 months. You have to monitor her HCG levels up till 6 months, right? So in which condition you have to assess her pregnancy test repeatedly? You have to do it repeatedly in molar pregnancy. How do you follow up a patient with RH incompatibility? RH incompatibility के patient में हम indirect comb test करते हैं, and अगर indirect comb test if it comes out to be positive, then you follow it up with peak systolic velocity of middle cerebral artery. I'm just writing it here. You follow it up with middle cerebral artery Doppler, and in middle cerebral artery Doppler you are going to look at peak systolic velocity, right? So how do you follow up a patient of RH incompatibility? RH incompatibility ke patient mein you don't do HCG levels, you do indirect comb test, and if indirect comb test comes out to be positive, you go for middle cerebral artery Doppler. Now you are asking, ma'am, drugs for mild PIH. For mild PIH, we do not use any hypertensives. If they ask you what is the management of mild PIH, Please remember, even whether it is mild or whether it is severe, initially हम सारे patients को admit करते हैं so that I can rule out severe PIH. Once I have ruled out severe PIH, I will discharge them. Right? You are not going to give any antihypertensive, no magnesium sulfate. Right? In patients ko you are not going to give any antihypertensives, you are not going to give them any magnesium sulfate, you are going to check their BP, you are going to check their liver function test and their platelet count. All these things will be checked and you are going to deliver them at 37 weeks. That is all what you do in mild PIH. No antihypertensive, no magnesium sulfate. Initially you will admit them. You will see कि कहीं इनके अंदर actually में ये patient severe PIH का तो नहीं है. Once you are sure that they belong to mild PIH, you are going to discharge them and you are going to tell them to regularly come to you and to get their BP monitored in their homes as well, and you are going to deliver them at 37 weeks. Right? Okay. Now, for previous neural tube defect, see, when I was telling you folic acid over here, please remember that folic acid, if you are beginning into all pregnant females, you begin them 1 month before conception. But in females in whom there is previous history of neural tube defect, you begin it 3 months before conception. But we are not astrologers. Imagine, क्या आप किसी भी patient को बता सकते हो कि 3 months from now you are going to become pregnant? No, you cannot tell. So although textbooks say 3 months before conception, ideally the answer is as soon as a female with previous history of neural tube defect thinks about conceiving, you should put her on 4 milligrams of folic acid. Right? And in both these cases, you are going to continue the folic acid up till 3 months after delivery. Clear? Okay. Next question was most common neonatal complication of gestational diabetes. Right? Now, please remember that in a case of diabetes, mother is going to have hyperglycemia. Same blood goes to the fetus. So, fetus also has hyperglycemia. Now, because of hyperglycemia in the fetus, fetal pancreas will produce insulin. So, there will be hyperinsulinemia. And because of this hyperinsulinemia in the fetus, there is going to be macrosomia. Right? Now, once the baby is born, the connection between mother and baby is no longer there. So, hyperglycemia ka source nahi raha. Glucose ka there is no source. What remains in the baby is hyperinsulinemia, because of which there will be hypoglycemia, hypokalemia, hypocalcemia, hypomagnesemia, hyperviscosity syndrome, that is polycythemia, and hyperbilirubinemia. All these babies, there are very high chances of respiratory distress syndrome because insulin decreases surfactant synthesis. There are increased chances of necrotizing enterocolitis. Right? Now, the complications which are never seen in babies of diabetic mother. So, in babies of diabetic mother, you will never have hyperglycemia. You will never have anemia. They have polycythemia. They never have anemia. And mental retardation. Right? So, most common complication of gestational diabetes. Is hyperglycemia a neonatal complication? No. Congenital malformation कभी भी gestational diabetes के babies में मिलता है? No. Congenital malformation is seen in pre-gestational diabetes. So remember, the most common neonatal complication of gestational diabetes is hypoglycemia. Right? Clear to all of you? Next question. A 26-year-old primigravida has come to you at 12 weeks pregnancy. She has lower quadrant pain and fever. Her ultrasound shows appendix which is 10 millimeters thick. And her WBC count is 18,000. Which of the following is done? So clear cut case hai appendicitis in pregnancy ka. Patient has come to you with lower quadrant pain, she has fever, and on ultrasound you are getting a 10 millimeter thick appendix, right? And whenever there is appendicitis in pregnancy, what are you going to do? In question number 26, first paper, why is answer not D? I'll have to go to question number 26. Just let me see what is the confusion which has occurred with you people. If you are going to message me so late, how am I going to know what question you are talking about? Okay. Why is answer not D? Please remember that in case of cancer cervix, after stage 2A2, from stage 2A2 onwards, you have to do chemoradiation. There is no role of surgery. So, आप ये नहीं कहोगे surgery followed by chemoradiation. No. Right? Your answer is only chemoradiation, no surgery. Clear? Surgery is done only up till stage 2A1. Clear to all of you? Now coming to my question, which was, appendicitis in pregnancy. So whenever there is appendicitis in pregnancy, management is immediate appendicectomy plus antibiotics and tocolytics, just in case patient has gone into preterm labor, right? So I am going to give her antibiotics and immediate surgery. So appendicitis in pregnancy means you have to go for immediate appendicectomy. Age doesn't count anywhere, beta. For management of cancers, age is not counting. Which of the following can cause cervical cancer? All of you know that HPV 16 and HPV 18 are the ones which lead to cancer cervix. Most common HPV causing cancer cervix is 16. Most specific is 18. Most common HPV causing squamous cell cancer is 16. Most common causing adenocarcinoma is 18. HPV 6 and 11, they are responsible for genital warts and laryngeal papillomatosis. Please remember, HPV के बारे में they also ask which protein of HPV is used for making HPV vaccines. So L1 capsid protein is used for making HPV vaccine. HPV vaccines is very important. India में recently बना है Sarvavac. Sarvavac is the first quadrivalent vaccine which has been made in India. Right? Now please remember that HPV vaccines, till now we were saying that HPV vaccines are given between age group 9 to 26. Recently HPV vaccines have also been approved for years 26 to 45. So high risk females may between 26 to 45 years also we can give HPV vaccines, right? Ideal age for giving HPV vaccines is 11 to 12 years. Now filter which is used in colposcopy. As I told you, colposcopy you have to do if pap smear result comes out to be abnormal. Then it has to be followed by colposcopy. And colposcopy karte karte hum biopsy lete hain, and the filter which is used in colposcopy is a green filter. With the help of this green filter, you will visualize abnormal blood vessels. So if you are a marrow subscriber, you know the procedure for colposcopy, right? Next question. Management of decubitus ulcer in a uterine prolapse. So why is there decubitus ulcer in a uterine prolapse? This decubitus ulcer is due to venous congestion. And how do you manage it? You manage it by doing packing. Ye packing, what are the things which you are using for packing? You are using acreflavin glycerine. Acreflavin plus glycerine. Acreflavin is an antiseptic agent and glycerine is a hygroscopic agent. Right? Next question. A multiparous female complains of dribbling of urine during coughing and laughing. That means whenever intra-abdominal pressure is increased, she is having dribbling of urine, and this is what you get in case of stress incontinence. Now, in case of stress incontinence, the best management is Bursch-Kolpo suspension. That is the best surgery. Right, but the most commonly done surgery is TOT. TOT stands for tension-free transobturator tape. Tension-free transobturator tape. If TOT is not given in the options, you are going to mark the answer as TVT. TVT is tension-free transvaginal tape, right? Now, why it is not vesicovaginal fistula? Vesicovaginal fistula के केस में patient will complain of continuously dribbling of urine. Patient will say she has continuous dribbling of urine. So it is not related to laughing, it is not related to coughing. There is continuous dribbling of urine, plus there is no normal urination. No normal urination, right? Jabki yahan pe patient is having dribbling only while coughing and laughing, and there is normal urination also which is present, right? Then a female presents with grayish white discharge, clue cells and positive whiff test. Now, whenever there is grayish white discharge, clue cells and positive whiff test, that means they are talking about bacterial vaginosis, right? Now, in case of bacterial vaginosis, the drug of choice is metronidazole. Bacterial vaginosis is not sexually transmitted, so no partner treatment is needed. And if the patient is pregnant, then also the drug of choice is metronidazole or clindamycin, right? So over here, the drug of choice is metronidazole. Please remember that if in case of bacterial vaginosis, you have a foul smelling discharge and there is no pruritus. Now, how do you distinguish bacterial vaginosis discharge from leukorrhea? In leukorrhea also the discharge is white. Here also the discharge is grayish white, right? In leukorrhea also there is no pruritus. There is no itching. But the difference is in leukorrhea there will be no foul smell, right? Whereas in bacterial vaginosis you are going to get foul smell, right? In case of trichomonas, your question will say that patient has a frothy yellowish green discharge, pruritus is present, dysuria is present, you get a strawberry vagina, whiff test can be present or it may be absent. Clue cells are present, right? And it is, clue cells are absent. Clue cells are absent. It is a sexually transmitted disease. So whenever you are getting a frothy yellowish discharge with pruritus present, whiff test may be present and you are getting a strawberry vagina, that means it is trichomonas, which is sexually transmitted disease. Drug of choice for trichomonas is also metronidazole. In trichomonas, partner treatment is needed, and in pregnancy, the drug which you give is metronidazole. In case of candida, the main complaint of the patient is pruritus. Discharge बहुत scanty होता है, right? And it is cottage cheese like discharge. You never get foul smelling discharge. pH of the discharge is less than 4.5. That's very, very important. एक ही condition है जिसमें pH of the discharge is less than 4.5 and that is candida, right? Now, in case of candida, the drug of choice is oral fluconazole in non-pregnant females. In pregnant females, it is topical clotrimazole. In case of candida, partner treatment is given only if the partner has symptoms. If the partner is symptomatic, then you give treatment. Now, for syndromic management of vaginal discharge, we use kit number 2, which is green kit. It has got fluconazole and instead of metronidazole, it has got secnidazole. Clear to all of you? Intense itching will be seen in case of candida, because as I told you, in candida the main complaint of the patient is pruritus, right? Next question. A young girl who has not attained menarche complains of cyclical pain in abdomen. Her breast development was normal. Local examination of the genitalia showed the following image. So this image was given. What are you seeing over here? You are seeing that there is imperforate hymen. You are seeing a bulging hymen, a tensed hymen, and that is why this is a case of imperforate hymen. Right? Okay. Next question. A patient is taking treatment for infertility and was given an ovulation trigger. The ultrasound of the pelvis shows some ascites and image is given below. The probable diagnosis is. Now, in this question, what you are seeing? In this question, you are seeing that you are getting big follicles inside the ovary, number one. Number two, they are saying that patient was taking some treatment for infertility, and now once the ovulation trigger was given, she had big follicles inside the ovary. Now I am confused. It can be a case of PCOS or it can be a case of ovarian hyperstimulation syndrome. Please remember, for PCOS, the diagnostic criteria is Rotterdam criteria. Rotterdam criteria says that out of the following three, any two should be present. What are the three? Number one, increase androgens, clinically or biochemically, ovulatory dysfunction, oligomenorrhea or amenorrhea, and polycystic morphology on ultrasound. Polycystic morphology on ultrasound का मतलब है more than equal to 12 follicles, 2 to 9 millimeters in size. राइट लेकिन अब नया क्राइटेरिया आ गया विच सेज मोर देन इक्वल टू 20 फॉलिकल्स 2 to 9 millimeters in size. So earlier they used to say कि PCOS की diagnosis के लिए you need more than equal to 12 follicles. Now they say more than equal to 20 follicles 2 to 9 millimeters in size. अब यहाँ पे हमें जो follicles मिल रहे हैं they are much bigger. Right? So whenever you are getting much bigger follicles which are more than 1 centimeter in size, it means it is a case of OHSS. OHSS is an iatrogenic complication. राइट ये कभी हमेशा ड्रग से होती है कभी नॉर्मली नहीं होती एंड विच इज द मोस्ट कॉमन ड्रग विच लीड्स टू OHSS HMG human menopausal gonadotropin followed by clomiphene citrate. Most common drug which leads to OHSS is HMG, right? So इसमें बहुत बड़े follicles मिलते हैं because you have overstimulated the ovary. ये जो HMG होता है it has LH and FSH. तो इसमें जो FSH होता है that leads to growth of the follicles and that is why you get big follicles. That is the difference between PCOS and OHSS. PCOS में you get small follicles, right? In OHSS you get big follicles. Clear? Which of the following is an absolute contraindication for IUCD? So remember the absolute contraindications for IUCD, whether it is copper IUCD or whether it is Mirena, there are 4 of them. Number 1, undiagnosed vaginal bleeding. Number 2, distorted uterine cavity. This distorted uterine cavity could be seen in cancer cervix, cancer endometrium or in congenital malformations. Then if your patient has current PID, right, or if patient has pregnancy. Now these are the contraindications for both copper IUCD and Mirena. इसके अलावा एक contraindication है only for copper IUCD which is Wilson's disease and one contraindication only for Mirena, that is if there is history of breast cancer, right? So over here previous history of ectopic pregnancy is not a contraindication. Previous history of PID is not a contraindication. Current PID is a contraindication. HIV positive female is not a contraindication. Undiagnosed vaginal bleeding is a contraindication. False statement regarding non-scalpel vasectomy. Now, even if you don't know many details about non-scalpel vasectomy, you know this, that sterility is not immediately attained after vasectomy. Right? After vasectomy, sterility is attained after 3 months. So sterility is attained after 3 months or after 20 ejaculates. So once I have done vasectomy, I advise the couple to use a barrier contraceptive, and then after 20 ejaculates, we will do 2 semen analysis, and if both the semen analysis say that the patient is azoospermic, then we tell them to stop using the barrier method, right? Now, over here they are saying hematoma formation may occur. Yes, it may occur. Recanalization is possible. Yes, it is possible. Sexual function following healing is rarely affected, and that is true. Sexual function is rarely affected. But remember, although recanalization possible hota hai after vasectomy, still vasectomy is taken as a permanent method of contraception. Whether it is tubectomy or whether it is vasectomy, you are not going to say that they are reversible methods. They are not reversible methods. They are permanent methods, right? Never say they are reversible methods. Another very important question is, what are LARC methods? LARC methods are long acting reversible methods. So what are long acting reversible contraceptives? In long acting reversible contraceptives, only 3 contraceptives comes: injections, implants, and IUCD, right? So these are long acting reversible method, LARC method. The answer to this question was option B. So they had asked false statement. So which is the false statement? Sterility is immediately attained after vasectomy. That's a wrong statement. It is attained after 3 months. Clear? Okay. Next question. Let's look at these instruments. These are 2 instruments which are used for vasectomy. This is a dissecting forceps and this is a ringed clamp. These are 2 instruments which are used for doing vasectomy. So it is a non-scalpel vasectomy where we don't use any scalpel. We are using a dissecting forceps and a ringed clamp. Why is this called as a forceps and not as a scissors? Because scissors में कभी भी ये नहीं मिलता. ये जो lock है ये नहीं मिलता. Lock is seen only in forceps. Lock is never seen in scissors. So this image C is a scissor, whereas image A is a dissecting forceps. So these are 2 instruments which are used in non-scalpel vasectomy. Next question. A lady with infertility undergoes laparoscopy for assessment of her fallopian tubes. Chromotubation was done and a dye was passed. The dye used for performing chromotubation. So please remember that investigation of choice for tubal patency is HSG, right? HSG के लिए जो आप instrument use करते हो, this is a funnel shaped instrument जिसको कहते हैं Leach Wilkinson cannula. HSG में the dye which is used is urographin, and the time for doing HSG is between day 7 to day 10. That is in the first half of the cycle, right? Between day 7 to day 10. What are contraindications for HSG? HSG should never be done in active PID patients, in active genital TB patients, and in suspected pregnancy patients. Now, this is the investigation of choice. But जब हम HSG करते हैं, the tubes undergo spasm, and that can lead to appearance of cornual block. That is why the gold standard test for tubal patency is laparoscopic chromoperturbation. It is not HSG. HSG is investigation of choice. Gold standard is laparoscopic chromoperturbation. In laparoscopic chromoperturbation, हम vagina के through we are going to pass a dye which is methylene blue dye, and simultaneously हम ऊपर से laparoscopy करेंगे. So from vagina we will pass a dye and ऊपर से हम laparoscopy करेंगे to see whether the dye is coming out or not. So this blue dye which you are seeing is used for laparoscopic chromoperturbation, and the dye which you are using is methylene blue dye. For HSG you use urographin, right? Meag syndrome is, now please remember, this is very, very important. Difference between Meag and pseudo-Meag. If you are a marrow student, you know this very well. Meag syndrome, there are 4 ovarian cancers. जिनके साथ if you are getting right-sided pleural effusion and ascites, you call it as Meag syndrome. What are the 4 ovarian cancers? Fibromas, thicomas, Brenner's tumor and granulosa cell tumor. So in case of fibroma, I'm writing it just quickly, properly for you here. So if you have a fibroma, a thicoma, a granulosa cell tumor, or a Brenner tumor, and along with this you are getting right-sided pleural effusion plus ascites, then this is what is called as Meeks syndrome, right? Fibroma is a solid, benign stromal tumor. ये stroma का tumor होता है and it is solid and benign. Thicoma is a malignant stromal tumor, right? Then you have a granulosa cell tumor which is again malignant, and Brenner's tumor. Brenner tumor is a benign epithelial tumor. Clear? Okay. So this granulosa cell tumor is a malignant sex cord tumor. Now, if you get right side pleural effusion plus ascites with any other condition, then that is what is called as pseudo-Meag syndrome. Pseudo-Meag syndrome, right? Now look over here. Meag syndrome is, so I told you it has to be a fibroma or a Brenner's tumor or a granulosa cell tumor or a thicoma along with ascites and hydrothorax. अब 2 options हैं fibroma के, benign and malignant. Fibroma is always a benign tumor. So the answer is benign fibroma plus ascites plus hydrothorax, right? Instead of benign fibroma, यहाँ पे क्या हो सकता था? It could have been malignant thicoma, it could have been benign Brenner's tumor, or it could have been malignant granulosa cell tumor. Then also I would have called it as Meag syndrome. Clear? No, Brenner's is not associated with pseudo-Meags. Bachcho, this is a change which has happened. Fibroma, thicoma, Brenner, granulosa cell. In चारों के साथ if you are getting ascites and hydrothorax, that is Meag, right? इनके अलावा if you are getting right-sided pleural effusion and ascites due to any other reason, then that's pseudo-Meag. Next, Bartholin cyst is located on. So all of you know Bartholin cyst is located in vestibule, right? So Bartholin cyst is located in vestibule. Bartholin gland का another नाम क्या होता है? Greater vestibular gland. What is the other name for Bartholin gland? Greater vestibular gland. Greater vestibular gland or Bartholin gland, it is homologous to Cowper's gland. Which gland is homologous to prostate gland? So it is the paraurethral glands, which are also called as Skene glands. Skene glands are homologous to prostate gland, right? Bartholin cyst, everything other than that I have already told you. Identify the instrument. Now this is very easy. What you are seeing over here is a curette. So this over here is a curette. Next, there was a question where they had shown you this instrument and they had asked you that the least likely use of this instrument. Now, in this instrument, what you are seeing that over here, this is a long instrument which has a bent. So, it is bent and this will have an olive tip. This is a uterine sound. This is a uterine sound. Now the uses of uterine sound are, so this is how you recognize a uterine sound. It is not straight, it has a smooth angle, it has an olive tip and it is calibrated. Now the uses of uterine sound are, uterine sound helps you to know the direction of the uterus before you do procedures like DNC or before you insert IUCD. Number 2, it can be used as the first dilator of the os. Number 3, it can be used for uterine anomalies like uterine septum को detect करने के लिए. Number 4, it can be used to confirm the position of misplaced IUCD. So if I am not sure कि IUCD is inside the uterus or outside the uterus, I can take a uterine sound and then do an ultrasound, right? To see whether the IUCD is near the uterine sound or it is not near the uterine sound, right? So these are the uses of uterine sound. So it can be used for dilatation and curettage. Yes. So before doing a dilatation and curettage, I can use uterine sound. Before suction evacuation, I can use a uterine sound to know the length of the uterus and the position of the uterus. For removing IUCD, I can use a uterine sound. For endometrial biopsy in India, we use Carmen's cannula. In India, we are using Carmen's cannula. Abroad, they are using a pipette, a pipel or a Vabra aspirator. A Vabra aspirator. Right, but in India, we are using a Carmen's cannula for endometrial biopsy. So this is the least likely use of a uterine sound. Epithelial lining of fallopian tube. That's a very simple question. The lining is ciliated columnar epithelium. Please remember there are two named cells which are present in fallopian tube. They are PEG cells and interstitial cells of Kagel. PEG cells का function हमें नहीं पता. Interstitial cells of Kagel, they are the pacemaker cells and they help to initiate fallopian tube contractions, right? So there are two named cells which are present in fallopian tube, PEG cells and interstitial cells of Kagel. The lining of fallopian tube is ciliated columnar. Identify the arrow marked in this image. So you have to tell whether it is a primary follicle or a primordial follicle or a preantral follicle or an antral follicle. So remember. Now, it's a very, very simple thing. Now, whenever you have a follicle and you have a single layer, so this is a primary oocyte which is surrounded by a single layer of flat cells. That is a primordial follicle. जैसे ही ये single layer of cells cuboidal में convert हो जाते हैं, you call it as a primary follicle, right? जैसे ही ये single layer की जगह multiple layers हो जाती हैं, and you start getting theca cells also. So now you are getting granulosa cells and theca cells. This is called as a secondary follicle, right? A secondary follicle is also called as a preantral follicle, right? So now when you are going to get, now if you get a cavity, the moment you start seeing a cavity and you will have multiple layers, यही granulosa cells की layers मिलेंगी, and you are going to get theca cell की proper layer. So you are getting theca cell, granulosa cell, and you are getting an antral cavity. This is what is called as antral follicle. And when the antral follicle is going to grow, And when antral follicle becomes 18 to 20 millimeter in size, it is called as Graafian follicle. So just before ovulation, antral follicle will become 18 to 20 millimeters in size and it will be called as Graafian follicle. So we start from primordial follicle. Primordial follicle mein there is a primary oocyte which is surrounded by a single layer of cells जो कि flat होते हैं. Then a primary follicle जिसमें ये cells cuboidal हो जाते हैं. Then you come to a secondary follicle or a preantral follicle जिसमें you get multiple layers of granulosa cell and some theca cells, and then a cavity appears and that is what is called as antral follicle. Right? Now in this image, when you zoom this image, you are seeing a cavity. Do you see a cavity over here? Now the moment you see a cavity, it means it's an antral follicle. Right? So this is an antral follicle. So the answer over here is option D. क्योंकि जब हम zoom कर रहे हैं हमें एक cavity दिखाई दे रही है. Now if cavity is seen, it means it's an antral follicle. Please do not say preantral. Preantral का मतलब है you will not see any cavity. Right? Okay. Then which of the following is not true about colostrum? So if you are a Marrow subscriber, or if you have watched my videos, or if you've attended my classes, I tell you to remember just one thing about colostrum. I tell you everything is more in colostrum. Only KFC is less in colostrum. Everything is more in colostrum in comparison to breast milk, whether it is immunoglobulins, whether it is anything. Everything is more in colostrum in comparison to breast milk except KFC. What is KFC? K stands for potassium, F stands for fat, and C stands for carbohydrates. So KFC is less in colostrum in comparison to breast milk, right? So over here it is saying which of the following is not true about colostrum. Colostrum contains IgA, yes. It is lemon yellow in color, yes. It has high amount of sugar and fat, no, right? So the incorrect answer is high amount of sugar and fat. So over here your option D is what you have to choose. Clear? Coming to the last paper where there were only 16 questions, FMG June 2022. Okay, now do you want to take a 5 minutes break or a 2 minutes break over here? Want to drink water? Just have water and then I'll quickly start June 2022 FMG paper. Hormone deficiencies in, what have you written? In, and so I can't even read. Hormone deficiencies in ambiguous genitalia. Hormone deficiencies in ambiguous genitalia. I don't understand which hormone deficiencies you want to understand. Matlab you want to, and what do you want me to tell you? Okay. So I am not taking a break. I'm just having some water. You people also, if you want to have water, just have water and we'll start June 2022. I will try to give you this PDF on my Telegram channel. I'll upload today's, if I am able to do. I am very bad on these technical aspects. If I am able to put it on my Telegram channel, I'll upload this PDF on my Telegram channel. Why methyl ergometrin is contraindicated in Rh negative pregnancy? See, methyl ergometrin has two drawbacks. One is it leads to high BP. That is why it is contraindicated in preeclampsia and in eclampsia. The other drawback of methyl ergometrin is it leads to tetanic contractions in the uterus. Oxytocin क्या करता है? When you give oxytocin, oxytocin leads to contraction and then relaxation. Contraction and then relaxation. लेकिन methyl ergometrin, if you are giving, it leads to tetanic contractions in the uterus. So when it leads to tetanic contraction in the uterus, whatever blood is there in the uterus, it goes back into mother's circulation. Right? That is why in heart disease you are never going to give methyl ergometrin, because as it is cardiac output is very high. अब अगर uterus का पूरा blood is going to go into mother's circulation, it will lead to heart failure. Number two, same problem in Rh negative. If it leads to tetanic contractions, there are increased chances of feto-maternal blood getting mixed. That is why it is not given. Explain congenital adrenal hyperplasia. अच्छा भाई, congenital adrenal hyperplasia is a big topic. Okay. At the end of the session, I'll take 5 minutes and I'll try to explain it to you in an easy manner. I will explain it to you. Don't worry. In the last, I'll explain congenital adrenal hyperplasia in an easy manner. Although I feel कि congenital adrenal hyperplasias पे in FMGE questions which are asked are few. You know, I have not, in the past few years, I have not seen questions on congenital adrenal hyperplasia in FMG. In INI set and in NEET, they are very oftenly asked. But still, I will explain. Okay. So coming to your June 2022 question, number 1. Which hyperthyroid drug is safer during first trimester of pregnancy? So whenever they are talking about hyperthyroid drugs, so remember, drug of choice for hyperthyroidism in pregnancy, if this is a plain simple question, they ask you what is the drug of choice for hyperthyroidism in pregnancy, your answer is going to be propyl thiouracil. If they ask you drug of choice for hyperthyroidism in first trimester, again the answer is going to be propyl thiouracil. If they say drug of choice for hyperthyroidism in second or third trimester, then the answer is going to be methimazole or carbimazole. Right? Now carbimazole and methimazole, they lead to one problem. That is why they are not used in first trimester, and that is aplasia cutis. Another very important question is, radioactive iodine is contraindicated in pregnancy. They can ask you what is the RDA. RDA is routine daily allowance of iodine in pregnancy. Routine daily allowance of iodine in pregnancy is 250 micrograms per day. Right? And the last thing which you have to remember is, suppose there is a hypothyroid female who was taking thyroxine and she conceives. So what are you going to do to the dose of thyroxine? So in all hypothyroid females, when they conceive, the dose of thyroxine should be increased. Right? Telegram channel's name is, I think, Dr. Sakshi. Just let me check. There are so many channels and so many things. Just let me check. OBGY by Sakshi Arora Hans. OBG by Dr. Sakshi Arora Hans. Right? I'll share the link in the comment section. Okay. So over here, your question was, which hyperthyroid drug is safer during first trimester? Propyl thiouracil. Methimazole and carbimazole, they can lead to aplasia cutis. And radioactive iodine is contraindicated. Next question. Which among the following is the most common cause of postmenopausal bleeding? Please, if a question comes like this, most common cause of postmenopausal bleeding is endometrial atrophy, which is also called as senile endometritis. right? Most common cancer causing PMB in India, that's cancer cervix. But most common cause of PMB is endometrial atrophy or senile endometritis. What do you understand by PMB? PMB is any bleeding which is happening after menopause. So you people have understood it wrong. कोई कहता है 6 months के बाद bleeding हो रही है तो PMB, 1 month के बाद bleeding हो रही है PMB. No. Any bleeding which is happening after a patient attains menopause, that is postmenopausal bleeding. And if they ask you what is the next step when a patient of PMB comes to you, the next step is you should do a transvaginal sonography. And on transvaginal sonography, you should look at the endometrial thickness. If endometrial thickness is more than 4 millimeters, then you should go for endometrial biopsy, right? So in all patients with PMB, if they ask you what is the next step, do not jump to endometrial biopsy. First step which you have to do is TVS. And on TVS, if it is the thickness is more than 4 millimeters, then you do endometrial biopsy. Now, which is the common duration of secondary PPH? As I told you that PPH can be primary or it can be secondary. If it is happening within 24 hours, it is primary. If it is happening after 24 hours but up till 12 weeks, it is secondary. So this was a very easy question. 24 hours to 12 weeks is secondary PPH. What is the most common cause of primary PPH? It is atonic uterus. What is the most common cause of secondary PPH? It is retained placental tissue, right? What is maternal mortality rate in India? 103, right? Next question. The legal requirement for MTP includes approval of 2 doctors among the following. Which time period best suits for this requirement? So, abhi we were talking about MTP Amendment Act, right? MTP amendment came in 2021 and according to this MTP amendment, the changes jo aaye hain, changes abhi we have done. Just now I told you a few of these changes, that now MTP can be done up till 24 weeks. If pregnancy is due to contraceptive failure, then MTP is done still only up till 20 weeks. If it is due to severe congenital anomalies, there is no upper limit to do MTP. A single doctor's opinion is needed till 20 weeks. Between 20 to 24 weeks, 2 doctors' opinion is needed. If you are doing MTP for severe congenital anomalies, then the medical board is formed and that medical board has 4 members and un charo ki opinion is needed, right? So over here they are saying 2 doctors' opinion. Now 2 doctors' opinion is needed between 20 to 24 weeks. A very important thing which I want you to remember is what are the qualifications for doing MTP. Any registered medical practitioner who has assisted in 25 cases of MTP, in which in 5 cases he or she should have been the primary surgeon, that is one requirement. Or any registered medical practitioner who has done house job in OBS and Gyne for 6 months can do MTP. Or any person, any MBBS person who has either MS in OBGY or MD in OBGY or DNB in OBGY or a DGO. So if there is a diploma or a degree of OBS and Gyne, then these 3 category of doctors are eligible to do MTP. All MTP records, for how long you should save them? You should save them for 5 years. Clear? Next question. A 34-year-old presents at 6 weeks of delivery. She wants contraception for next 3 years. What will be the best contraceptive method in this case? Right. Now, very important, because it has been asked in your June 2022 exam, is contraception in the postpartum period. So I am just going to take 5 minutes to explain you this question. Now, when you are using contraceptive after delivery, in a fully breastfeeding female, contraceptive should begin 3 months after delivery. In a partially breastfeeding female or in a female who's not breastfeeding, right, the contraceptive should begin 3 months after delivery, right? Now, in case of IUCD, when can you put IUCD in a female who has recently delivered? You can put IUCD in a female within 48 hours of delivery. If you put IUCD within 48 hours of delivery, that is called as postpartum insertion. लेकिन अगर आपने 48 hours में IUCD नहीं डाला, तो then you cannot put up till 6 weeks after delivery. Right? So either you put it within 48 hours of delivery or you put the IUCD after 6 weeks of delivery. Now there are two IUCDs which we have, copper IUCD and progesterone IUCD, which is Mirena. Remember, Mirena is the most effective amongst all contraceptive methods, right? The failure rate of Mirena is 0.05%. And क्योंकि Mirena में progesterone होता है, progesterone has no effect on breast milk, right? Progesterone will have no effect on breast milk. Clear? Now, when we talk about OCPs, OCPs, that is estrogen and progesterone containing pills, they have two problems. Number one, they decrease breast milk. And number two, there are increased chances of venous thromboembolism. That is why in a fully breastfeeding female, they are absolutely contraindicated till 6 weeks. Ideally, an OCP should be given to a fully breastfeeding female from 6 months onwards, right? Even if the female is not breastfeeding or partially breastfeeding, still I will be thinking whether to give OCP or not. Why? Because OCPs lead to increased chances of venous thromboembolism, and as it is in pregnancy, the clotting factors were high. So even if the female is not breastfeeding, I am not worried about कि breast milk कम हो जाएगा because she is not breastfeeding. I am worried about venous thromboembolism, and that is why OCPs are absolutely contraindicated at less than 3 weeks of delivery. Ideally, they should be started at more than equal to 6 weeks if a female is not breastfeeding. Right? Now, when it comes to progesterone containing contraceptives, progesterone containing contraceptives like POPs, like implants. POPs and implants, प्रोजेस्ट्रॉन का कोई प्रॉब्लम नहीं है. प्रोजेस्ट्रॉन ना तो ब्रेस्ट मिल्क डिक्रीज करता है, ना ही प्रोजेस्ट्रॉन एम्बोलिज्म कॉज करता है, राइट? So progesterone containing contraceptives, whether it was POP, whether it is a progesterone implant, you can start from day 1 of delivery, right? चाहे वो breastfeeding कर रही है या नहीं कर रही है, hardly matters. In all females after delivery, you can start POPs or progesterone implant can be put from day 1. As far as injection is concerned, DMPA is concerned. DMPA में केवल एक ही प्रॉब्लम है. DMPA जब आप यूज करते हो, it decreases the bone mineral density. That is why in a breastfeeding female, it is contraindicated till 6 weeks after delivery, right? So in a gist, I have told you कि IUCDs can be put within 48 hours of delivery or they can be put after 6 weeks of delivery, right? OCPs, ideally OCPs को in a breastfeeding female हमें 6 months after delivery start करना चाहिए, but they are absolutely contraindicated till 6 weeks after delivery. But in a breastfeeding female, I'm going to start it ideally after 6 months. Progesterone containing pill हो या implant हो, you can start it from day 1 of delivery, right? And injection, DMPA. In a breastfeeding female, you should start from 6 weeks after delivery. Now, with this knowledge, let us come to this question. Your question is saying patient has come to you 6 weeks after delivery and she wants a contraception for next 3 years. So, lactational amenorrhea is not an answer, right? Because patient breastfeed karegi, so injectable progesterone is also not an option. Because injectable progesterone का मतलब है after every 2 months you have to give the injection also, and she wants a contraceptive for 3 years. Now I am left with 2 options. Copper T दे कि IUCD with progesterone दें, right? Now, if you ask me, both of them can be given. You can give copper T also and you can give Mirena also. Mirena का advantage ये है कि it is the most effective contraceptive method. So it's most effective contraceptive method, and if since it is the most effective contraceptive method, I would prefer giving her Mirena. Now, clear to all of you, since it is the most effective contraceptive method, its failure rate is 0.05%. So I am going to prefer giving her Mirena in comparison to copper IUCD. अब प्रॉब्लम कहाँ आती है? प्रॉब्लम ये आती है that when you give Mirena, the patient experiences amenorrhea. Patient continuously amenorrhea में चला जाता है, right? Patient has amenorrhea. Patient will not have any bleeding, right? And because patient will not have any bleeding, she will not be very, a patient wants bleeding so that she is sure that pregnancy has not happened, right? And on top of that, patient ने अभी अभी डिलीवरी करी है, तो she wants to be very sure that I am not pregnant. And हमने उसको ऐसा कॉन्ट्रासेप्टिव दे दिया जो कि amenorrhea कॉज कर रहा है. She will always be very tensed, right? And that is why the preferred contraceptive is copper T, because copper T से patient will have bleeding, so she will be sure that uski periods aayenge, so she will be sure that she is not pregnant. Although Mirena is the most efficacious one, maximum efficacy Mirena ki hoti hai, but still over here the answer will be copper T. Clear? Which of the following drug is used for MTP for a 20-year female who has come to you in early weeks of pregnancy? And just now we did that medical abortion ke liye you are going to use 200 milligrams of mifepristone, and early weeks में we use 400 micrograms of misoprost, and later on we use 800 micrograms of misoprost. And यहाँ पे केवल एक ही ऑप्शन था जिसमें 200 milligrams of mifepristone दिया था, which was option C, and that was with 800 micrograms of misoprost, so I'm marking that as the answer. Identify the image. Now in this image it is very clear what you are seeing. You are seeing that the placenta is covering the os, and because placenta is covering the os, this is a case of placenta previa. Nowadays we do not use type 1, type 2, type 3 or type 4 placenta previa. Nowadays we use only two terminologies, low lying placenta and placenta previa. Low lying placenta का क्या मतलब है? Low lying placenta का मतलब है कि placenta is within 2 centimeters of the internal os, but it is not touching the internal os, right? And placenta previa का क्या मतलब है? Placenta reaches up till the edges of the internal os, or it covers the internal os. That is placenta previa, right? Then a 24-year-old patient presented in emergency room with fully outside cervix. So her uterus was outside and a cystocele. What is the next step in management? Now please understand that this patient is coming to you in emergency room, right? Cystocele की patient अगर emergency room में आ रही है, this means she is coming to you with urinary retention, right? Because there is urinary retention, that is why she is coming to you. And if they are asking you what is the next step, तो emergency room में आने के बाद हम उसको cystocele repair के लिए नहीं ले जाएंगे. Next step will not be cystocele repair. Next step is going to be that I am going to put a Foley's catheter and I am going to make her uterus be inside, क्योंकि if the uterus is inside she will be able to pass her urine. Otherwise हर थोड़े दिन बाद जब तक का हम सर्जरी नहीं करते तब तक का every time she will have urinary retention, so that उसको next time अब urinary retention ना हो. इस बार urinary retention के लिए तो हम Foley's catheter डालेंगे, and so that अब आगे urinary retention ना हो, I want the uterus to be in a normal position, and that is why I am going to put a pessary, right? So this is the next step in management, Foley's catheterization plus a pessary. So a pessary for temporary relief. What if they ask you what is the management of cystocele? Now, whenever they ask you management of cystocele in all age groups is anterior colporrhaphy. Similarly, management of erythrocele in all age groups is anterior colporrhaphy. Management of rectocele is posterior colpoperineuraphy, and management of enterocele is Moskowitz repair. Moskowitz repair, right? Now please remember, cystocele हो या urethrocoele हो या enterocele हो या rectocele हो, इनका management same होता है for all age groups, right? But in case of uterine prolapse, management differ करता है in different age groups. First of all, uterine prolapse should be managed only if it is a 3rd degree uterine prolapse, right? Now, if there is a 3rd degree uterine prolapse which is happening in a young female जिसमें childbearing is not completed, then the prolapse is managed by a sling surgery or cervicopexy. If it is a reproductive age female who जिसको prolapse हुआ है, her childbearing is complete, right? Then the management is Fothergill's repair. If it is a postmenopausal female with a 3rd degree prolapse, management is hysterectomy. If it is a postmenopausal female with comorbidities like उसको diabetes है या heart disease है and उसको 3rd degree prolapse हुआ है, then it is Lefort's colpoclysis. Now, if there is a pregnant female or a postpartum female with prolapse, or if there is a female who's very elderly, who's more than 65 years of age and she has a prolapse, then the management is pessary. This pessary is only for temporary relief and it has to be changed after every 3 months. Clear? Identify the image. Now, in this image, what you are seeing is that there is a connection which is present between the bladder and vagina. Now, because a connection is present, yes, if a patient is more than 65, you have to give a pessary. So, whether she is 80 or whether it is more than 65, you have to give a pessary. Now, over here, you are seeing a connection between the bladder and vagina, and that is what is vesicovaginal fistula. So this over here is bladder, this is uterus, this is vagina, right? And this over here is a vesicovaginal fistula. Now, in case of vesicovaginal fistula, so there are basically 3 kinds of fistulas on which question can come. A uretrovaginal fistula, vesicovaginal fistula and urethrovaginal fistula. Uretrovaginal fistula का मतलब है कि ureter and vagina के बीच में fistula है. In this case, patient will complain of dribbling of urine plus she will have normal urination. So there will be continuous dribbling of urine and normal urination, and when you will do a methylene blue test, you will see that the upper swab is wet but there is no color, right? In case of vesicovaginal fistula, when the fistula is between bladder and vagina, the patient will come to you with dribbling of urine but there will be no normal urination. So कभी भी patient को normal urination नहीं होगा, only dribbling of urine होगा. जबकि in uretrovaginal fistula normal urination भी होगा and dribbling भी होगा. And when you will do a methylene blue 3 swab test in vesicovaginal fistula, middle swab will be wet plus blue in color. In case of urethrovaginal fistula, there is no continuous dribbling of urine. There is no continuous dribbling of urine patient will complain of urine coming out from urethra and vagina at the time of urination. So patient will say that when I sit for urination, urine comes out from my vagina also. And when you will do a methylene blue 3 swab test, so in a methylene blue 3 swab test, the lowermost cotton swab will be wet plus blue. Now, if they ask you what is the best investigation for vesicovaginal fistula, it is cystoscopy. Right? What is the most common cause of VVF in India? Most common cause of VVF in India is obstructed labor. That's the most common cause of VVF in India. Right? Next question. WHO defines maternal death as. So how does WHO define maternal death? WHO defines maternal death as death during pregnancy and within 6 weeks of delivery. Please remember, maternal mortality rate in India is 103, and the most common cause of maternal mortality is obstetrical hemorrhage. In obstetrical hemorrhage, the most common is postpartum hemorrhage. Then a couple came to clinic with complaint of infertility. On examination, her husband had gynecomastia and tall stature. What is the possible diagnosis? Now, they had given you option of Klinefelter, Turner, Swires and testicular feminizing syndrome. Remember कि Turner's, Swires and androgen insensitivity syndrome, जिसको testicular feminizing syndrome भी कहते हैं, in all these cases your patient is a female patient. So phenotypically patient is female patient, right? And patient primary amenorrhea की तरीके से आएगी, राइट? कभी भी ऐसा नहीं होगा कि वो एक मेल होगा. टर्नर सिंड्रोम की पेशेंट इज अ फीमेल पेशेंट, स्वायर्स सिंड्रोम की पेशेंट इज अ फीमेल पेशेंट, एंड एंड्रोजन इनसेंसिटिविटी सिंड्रोम की पेशेंट इज अ फीमेल पेशेंट. सो इफ यू नो दिस मच, यू नो दैट द आंसर इज गोइंग टू बी क्लाइनफेल्टर सिंड्रोम, बिकॉज यहाँ पे क्वेश्चन कह रहा है कि द पेशेंट्स हस्बैंड was tall and had gynecomastia, right? So this is what you get in Klinefelter syndrome. In Klinefelter syndrome, the chromosome number is 47XXY, and because they have Y chromosome, they are males and they have testes as their gonads. Right? These testes are small and they are hypoplastic. That is why there is testicular failure, and that is why there is infertility. These individuals, they have tall stature and they have long limbs, and because they have X chromosomes, so they have some female features like gynecomastia and high pitched voice. So Klinefelter syndrome के patients are male patients who are tall, who have long limbs, and they have testes. The testes are small and hypoplastic. They have two X chromosomes, so they have gynecomastia and they have a high pitched voice, right? On the other hand, Turner syndrome, Swires syndrome and androgen insensitivity syndrome, phenotypically, that means physical appearance wise, all of them are females, and they come to you with complaint of primary amenorrhea. The most common cause of primary amenorrhea is Turner's syndrome. Turner syndrome पे जब भी question आएगा that patient has come to you with primary amenorrhea and she has short stature, right? They may say कि webbing of neck present है, uterus will be present, and their gonads will be ovaries, but ovaries will not be functioning properly. There will be streak ovaries and these streak ovaries will produce decreased estrogen, and क्योंकि estrogen नहीं होगा, that is why breast development will be absent, and because estrogen नहीं होगा, so the negative feedback on FSH will go, and so the FSH levels are high. So this is what you have to remember in Turner's syndrome. Primary amenorrhea, short stature, streak gonads, that means less estrogen, that means breast development not proper, and that means that FSH levels are high. Uterus is present in Turner's syndrome. Now, then comes Swyer's syndrome. Swyer's syndrome is 46XY. Now, because it is 46XY, that is why the gonads are testes. But again, they come to you as a case of female with primary amenorrhea. Differentiate कैसे करोगे Turner's syndrome से? They will have normal stature. Rest everything is same between Turner's and Swyer's. क्या डिफरेंस होता है टर्नर्स एंड स्वायर्स में? टर्नर्स इज 45XO. टर्नर्स में स्ट्रीक ओवरीज होती हैं एंड टर्नर्स में शॉर्ट स्टेचर होता है. स्वायर्स इज 46XY. उसमें टेस्टीज होती हैं एंड नॉर्मल स्टेचर होता है. बाकी दोनों में सब कुछ सेम होता है, दोनों में यूट्रस प्रेजेंट होता है, दोनों में FSH लेवल्स हाई होते हैं एंड दोनों में ब्रेस्ट डेवलपमेंट इज एब्सेंट. Right? So this is how you come to know whether it is Turner's or Swyer's based on testes and ovaries, based on normal stature and short stature, and based on chromosome number. Then comes androgen insensitivity syndrome. Androgen insensitivity syndrome में again it is 46XY. The gonads are testes, right? But their uterus is absent. They will never have a uterus. Breast development इनमें proper breast development होगा, जबकि Swyer's में breast development नहीं था, right? Swyer's में uterus present था, breast development present नहीं था. Androgen insensitivity में uterus present नहीं है, but breast development is proper breast development and pubic hair is less. So proper breast development but less pubic hair. Swyer's में तो ना तो pubic hair होता है ना breast development होता है. Turner's में भी ना तो pubic hair होता है ना breast development होता है, right? लेकिन androgen insensitivity में breast development होता है but pubic hair नहीं होता है, and I explained it to you earlier. Breast development इसलिए होता है because androgens get converted into estrogens, and estrogen is needed for breast development, and these individuals are insensitive to androgens. Androgens are needed for pubic hair, that is why pubic hair is not there, right? Now, a patient with breast cancer treatment who was on tamoxifen, she now presents with complaints of bleeding per vagina. What is the most likely cause? Please remember, tamoxifen is a selective estrogen receptor modulator drug which can lead to endometrial cancer. Very, very important. Tamoxifen can lead to endometrial cancer. Okay, someone is asking me androgen insensitivity syndrome versus Mullerian agenesis. Very easy. Let us see. Androgen is 46XY, Mullerian is 46XX. दोनों में uterus absent, right? Gonads in androgen insensitivity, testes. Over here, ovaries. Breast development दोनों में present. Pubic hair absent in androgen insensitivity, present in Mullerian agenesis. Renal anomalies present in Mullerian agenesis, absent in androgen insensitivity syndrome, right? So androgen insensitivity syndrome and now if you look at testosterone levels in androgen insensitivity, because ये males हैं, मतलब ये 46XY हैं, right? So that is why in comparison to a female, the levels of testosterone will be very high. यहाँ पे normal testosterone levels होंगे. right? Clear to all of you? Yes? Okay. Next question. This instrument is used for, abhi humne kiya, this is a Leach Wilkinson cannula, and this Leach Wilkinson cannula is used for HSG. Next question. Retrodrine to prevent premature labor will cause all of the following complications in mother except. So what is Retrodrine? Retrodrine, all of you know from your pharma knowledge that this is a beta 2 agonist, right? So it is a beta 2 agonist, and all beta 2 agonists can lead to tachycardia, they can lead to tremors, they can lead to pulmonary edema. They do not lead to hypoglycemia, they lead to hyperglycemia. What is the tocolytic of choice in India? Tocolytic of choice in India is nifedipine. Please remember, all tocolytics should be given only for 48 hours, and tocolytics should never be given in pregnancies which are more than 34 weeks. So you don't give tocolytics in pregnancies which are more than 34 weeks. Endomethacin is also a tocolytic. Endomethacin should never be given for more than 32 weeks. It should never be given beyond 32 weeks. Why? Because if endomethacin is given beyond 32 weeks, it leads to premature closure of ductus arteriosus, right? So tocolytic of choice is nifedipine. Tocolytics should only be given for 48 hours, and they should never be given after 34 weeks. What is the role of tocolytics? Tocolytics का केवल एक ही role होता है, they give time for corticosteroids to act. So they buy time. When I want to buy time for corticosteroids to act, then I'm going to give tocolytics, and I'm going to give tocolytics only up till 48 hours, not more than that. And never am I going to give tocolytics after 34 weeks. Endomethacin is a tocolytic which should never be given beyond 32 weeks because it can lead to premature closure of ductus arteriosus. Please remember, progesterone is not a tocolytic. It can prevent preterm labor, but it cannot treat preterm labor once the contractions begin. So do not say progesterone is a tocolytic. Progesterone is not a tocolytic, right? Then identify the image. Now in this image, what you are seeing? In this image, you are seeing that a dye was passed. ये HSG का cannula है. Dye pass हुआ, and dye pass होने के बाद बीच में नहीं आया in the uterus, and over here it didn't come. This is something which is called as filling defect. Filling defect. I am seeing that the dye didn't come at some places inside the uterus. So remember, in HSG, in HSG, if you are getting multiple small irregular filling defects, that is called as moth-eaten appearance, then you are dealing with a case of Asherman syndrome. If you are getting a single defect which is very smooth and regular, then that means it's a case of fibroid or polyp, right? If you are getting lead pipe appearance, beaded appearance, tobacco pouch appearance, golf stick appearance, cotton wool appearance, or bilateral cornwall block, then that is genital TB. In genital TB, हम HSG नहीं करते. But by chance, I am not knowing my patient has genital TB, and if I do HSG, what are the typical findings which you get on HSG in genital TB? ये नाम याद करने हैं. Lead pipe appearance, beaded appearance, tobacco pouch appearance, golf stick appearance, cotton wool appearance, or bilateral cornwall block. So HSGs के बारे में केवल इतना याद रखना है कि अगर multiple irregular filling defects मिल रहे हैं तो Asherman syndrome, single smooth regular filling defect मिल रहा है तो either it is fibroid or polyp, और अगर इनमें से कोई word दिया गया है तो that is genital TB. अब यहाँ पे I am seeing two defects. It is not a single defect and it is irregular. That means this is a case of Asherman syndrome. Right? In case of unicornuate uterus, you get a banana shaped uterus. You get a banana shaped uterus in a unicornuate uterus, right, on HSG. So HSG में you are going to get an image like this, a banana shaped uterus. इतना सा दिखेगा, एक साइड की fallopian tube दिखेगी, right? So you are going to get banana shaped uterus plus single fallopian tube. So किसी भी HSG में single fallopian tube दिखे, it means it is unicornuate uterus, right? यहाँ पे I can see कि ये I want all of you to first look at this HSG very carefully. This over here is one fallopian tube and this is the dye coming out, and this over here is second fallopian tube and dye coming out. This means कि कोई blockage नहीं है, there is no block. राइट तो HSG के क्या क्या यूजेस होते हैं? HSG का नंबर 1 यूज होता है कि हम ब्लॉक्स आइडेंटिफाई कर सकते हैं. एंड जस्ट नाउ वी डिड कि इफ यू आर गेटिंग बायलेटरल कॉर्नुअल ब्लॉक, most common cause is spasm. Second most common cause is genital TB. If you are getting a fimbrial block, then that is mostly due to salpingitis due to gonorrhea. इस HSG में कोई ब्लॉक नहीं है. इस HSG में हमें डाई नीचे आती हुई दिख रही है. Right? In this HSG, I can see the uterus properly. I can see two fallopian tubes. That means it is not any uterine anomaly. क्योंकि अगर unicornuate uterus होता तो I would have got a banana shaped uterus and I would have got a single fallopian tube. Right? This is not a normal HSG because I am getting a filling defect. Septate and bicornuate. Okay. Now, septate and bicornuate, they are very difficult to differentiate on HSG. Agar HSG में, so I want all of you to copy this. If on HSG you are getting a single fallopian tube, it means it is unicornuate uterus. Right? If on HSG you are getting two fallopian tubes and simultaneously you see that there are fallopian tube तो दो हैं. अब fallopian tube दो तो normally भी होते हैं. And now what you are seeing is that there are two vaginas. How do I come to know there are two vaginas? Because there are two Leach-Wilkinson cannulas. दो Leach-Wilkinson cannula use हुए हैं. Right? Then that means it is didelphys uterus. I'll just now show you an image of didelphys uterus, right, where you will get two Leach-Wilkinson cannulas, right? Now, if you see on HSG that there are two fallopian tubes, single vagina, but you are getting two uterus. वेजाइना सिंगल है लेकिन यूट्रस दो दिख रहे हैं. राइट? यहां पे वेजाइना भी दो थे, यूट्रस भी दो थे. राइट? सो नाउ इट कैन ईदर बी बाइकॉर्नुएट or it can be septate uterus. Now, in a bicornuate uterus, you will get two uterus, single vagina, two fallopian tubes. In septate uterus also you will get two fallopian tubes, two uterus, single vagina. Now how am I going to differentiate between them? If the distance between the two horns is more than 4 centimeters and angle is more than 60 degrees. So it's an obtuse angle. 60 की जगह बोलो obtuse angle. Right? If distance is less than 4 centimeters and there is an acute angle, then it is septate uterus. So if you are getting confused, just let me check. Let me show you some images. So look here. What are you seeing in this image? In this image, what are you seeing? In this image, you are seeing, this is a Leach-Wilkinson cannula. You are seeing a banana shaped uterus and you are seeing a single fallopian tube. Because you are seeing a single fallopian tube, a banana shaped uterus, that means this is a case of unicornuate uterus, right? Now I want you to look at this image. In this image, what you are seeing? In this image, you are seeing two fallopian tubes. अब दो fallopian tube दिख रही हैं तो it cannot be unicornuate uterus, right? But I am seeing two fallopian tubes. I am also seeing two vaginas because I am seeing two Leach-Wilkinson cannulas. Now because there are two Leach-Wilkinson cannulas, that means it is a case of didelphys uterus. Clear to all of you? Yes? Now look at this image over here. In this image, I am seeing two fallopian tubes. Two fallopian tubes. So this cannot be unicornuate uterus. I am seeing a single Leach-Wilkinson cannula. So it cannot be didelphys. अब या तो ये bicornuate है या ये septate है. Right, so now look at the angle between the two horns and the distance between the two horns. The angle between the two horns is obtuse and distance is more than 4 centimeters. This is bicornuate uterus. Compare it with this image over here. In this image, again I am seeing two fallopian tubes, so it cannot be unicornuate. I am seeing single Leach-Wilkinson, it cannot be didelphys. So either it is bicornuate or septate. Now the distance between the two horns is less than 4 centimeters and it is acute angle, so this is septate uterus. Clear to all of you? Yes? Okay. So all your confusions gone? And if you are getting multiple filling defects, it is Asherman syndrome, single smooth filling defect, fibroid or polyp. Clear to all of you? Now, what will be the content in the given contraceptive? So the contraceptive given to you was today's sponge. All of you know that today's sponge has got 1 gram non-oxynol 9. And the best part about today's sponge and the most characteristic thing about today's sponge is that once today's sponge is inserted, it can be used multiple times in that 24 hours. एक बार 24 hours के लिए today's sponge को जब एक female insert करती है, she can use it for multiple times in that 24 hours. So this is one of the best contraceptive for a female sex worker, right? Maximum today's sponge can be left for 30 hours. But the chances of toxic shock syndrome are nil. If you do not remove it after 30 hours, the chances of toxic shock syndrome are nil. But the problem with today's sponge, that why we don't say that this is the contraceptive of choice for a female sex worker, is because today's sponge can protect against STD and PID but not HIV. That is why we don't call it as the contraceptive of choice for a female sex worker, right? Then What should be the treatment of 8 centimeter endometrial cyst? So remember, a chocolate cyst or an endometrioma, it is never managed medically. Always you have to do a surgical management. If the size of the cyst is less than 5 centimeters, you don't have to do anything. You have to just follow up with TVS. But if size is more than equal to 5 centimeters, you have to do a laparoscopic cystectomy. So over here they have given 8 centimeters, so I am going to do a cystectomy. Right? You never do medical management for a chocolate cyst or endometrioma. Right? A typical thing about chocolate cyst is on ultrasound, cyst normally should appear pure black in color. Lekin a chocolate cyst will never appear pure black in color. It will give you a picture like this, which is called as ground glass appearance. This क्वेश्चन में कभी कभी ग्राउंड ग्लास अपीयरेंस की जगह दे कैन राइट अ cyst with homogeneous internal echoes. जब भी कहीं ये आए कि there is an ovarian cyst with homogeneous internal echoes, that means it is a chocolate cyst. Ground glass appearance or homogeneous internal echoes. So that brings me to the end of today's long session which we had. We have discussed all the PYQs. All the best to all of you. I'm sure all of you are going to do really well. A few things which I want all of you to do is, please do not wake up till late night tomorrow. ये गलती बिल्कुल मत करना. ऐसा बिल्कुल मत करना कि सो मत. Right? You have to sleep on time tomorrow. Rather, I would suggest कि आज भी time से सो and get up early tomorrow morning, and then tomorrow night sleep on time. Have a proper meal at night tomorrow. Don't stay hungry. Don't read anything new tomorrow. Don't get nervous. Just revise. If you've made a 20th notebook, revise that, or just do previous year questions. That is all what you need to do. Don't go for anything new now. Right? So all the best to all of you. I'm sure all of you are going to do really well. Please keep your admit cards ready. Please keep everything what you need for your exam at one place. Day after tomorrow morning, get up on time. Day after tomorrow morning, you are not going to study anything. Just get up, take your shower, have some light snacks. Don't go empty stomach. Right? Take blessings of God, take blessings of your parents, and be confident and just write your exam. And don't forget to send me your, how your paper had been on Instagram. On Instagram, I'll be waiting for your messages that how your exam had gone. All the best to all of you. You are going to do really, really well. Any questions which you want to ask? Yes, you can see this video again tomorrow. This video is going to be there, and I'm also going to share the PDF tomorrow with you. Rather, tonight I'll try to share this PDF on my Telegram group. All the best. Love you all so much. A bit about ligaments and supports. Okay, ligaments and supports of the uterus. Very easy. कुछ नहीं करना इसमें. Remember the ligaments which support the uterus. So if this over here is pubic symphysis, this is sacrum, and this is pelvic side wall. This is the uterus. So number one ligament is pubocervical ligament. Number two is a ligament which is connecting uterus to the pelvic side wall. This is called as McInrod's ligament. This is also called as transverse cervical ligament, and this is also called as cardinal ligament. And then there is a ligament which connects uterus to posteriorly the sacrum, which is called as uterosacral ligaments. All these three are the main ligaments or the primary ligaments which support the uterus, right? Out of this, the most important is cardinal ligament. Overall, if they ask you which is the most important support of the uterus, overall the most important support of the uterus is levator ani muscle, right? Now, if there is a secondary support of the uterus, these were primary supports along with levator ani, that's the primary support. Secondary support is a ligament which is called as round ligament. Round ligament indirectly supports the uterus because it helps to keep the uterus in anteverted position. As long as uterus is anteverted, anteverted ka matlab there is the uterus is flexed, there is an angle between vagina and cervix and there is an angle between cervix and uterus, right? So the angle between vagina and cervix, that is what is called as angle of anteversion. yahan pe aage bladder hota hai, as long as uterus is anteverted, bladder usko fall nahi karne deta. जैसे ही यूट्रस रेट्रोवर्टेड हो जाता है, right, वैसे ही it becomes easier to fall, right? So anteverted position helps to keep the uterus in, helps preventing prolapse, right? So because round ligament keeps the uterus in anteverted position, that is why it indirectly supports the uterus. Now a ligament which never supports the uterus, that is broad ligament. Broad ligament never supports the uterus, right? Okay, what instruments are important? In instruments, I want all of you to look at Sims speculum, Cusco's speculum. Then I want you to look at anterior vaginal wall retractor, a uterine sound, curate. Then I want all of you to look at ovum forceps, right? Then you should look at Cocker's forceps, because Cocker's forceps is used for ARM, right? Then you should look at Carmen's cannula. Many times they have asked you Carmen's cannula. Then a myoma clamp. Look at a myoma clamp and a myoma screw. Right? So broadly, these are the ones which are very important. Okay. Then episiotomy scissors. Very important that you look at the episiotomy scissors. Yes, Cocker's is with teeth. A Cocker's forceps mein there is one tooth like this and two teeth like this. Okay. MVA syringe तो अभी हमने किया, so yes, MVA syringe. You are going to look at it. Then you are going to look at Ayer's spatula and a brush, a cervical brush, endocervical brush. Yes, Hagar's dilators are important. Clear? Now, anything else? Nothing, it's done. Bishop score, what do you want to know? I mean, there are Bishop score. I want all of you to remember biophysical score ke parameters. You don't have to remember the details of Bishop score. You just need to know the parameters in Bishop score and parameters in biophysical score. Iske alawa, you don't need to remember the score in details. Clear? Okay. Images may look at the CTG image. Deceleration, early deceleration, late deceleration, and your variable deceleration and sinusoidal heart rate pattern. ये 3-4 images भी जरूर से देख लेना. Then chorionic villi sampling की image and amniocentesis की image. These images are very important for you. Look at these images. Take care, all of you. What is you asking? How to remember staging in gynae cancers? Staging in gynae cancers, देखो, you don't get questions on staging in gynae cancers. Most of the times you will not get any question. If you are remembering staging, well and good. अगर staging याद नहीं है, तो remember only what I am telling you just now. In choriocarcinoma, remember that lungs are involved in stage 3. Right? In endometrial cancer, remember cervix is involved in stage 2. Right? अब जो endometrial cancer की stage 3C है एंड कैंसर सर्विक्स की जो स्टेज 3C है, दोनों की सेम है. रिमेंबर 3C1 का मतलब है पेल्विक लिम्फ नोड्स का इन्वॉल्वमेंट, 3C2 का मतलब है पैरा आयोटिक लिम्फ नोड्स का इन्वॉल्वमेंट. राइट, क्वेश्चंस इनमें से ही आएंगे, इसके अलावा नहीं आएंगे. देन सुपरफिशियल इंग्वाइनल लिम्फ नोड. Superficial inguinal lymph node, whether it is endometrial cancer, whether it is cancer cervix, whether it is cancer ovary, in तीनों में they are involved in stage 4B. Right? तो lymph node कौन कौन से cancer में कब कब involve होते हैं, that is important. So lymph nodes you have to remember. Then you have to remember that in cancer cervix, ureter is involved in stage 3B. Right? Bladder is involved in stage 4A. So if you remember this much, your purpose is done. इससे ज़्यादा नहीं पूछा जाएगा. Staging as such is not asked. Clear? So all the best. Take care. Don't get nervous. You people have studied so much that you are going to clear. इस time पे nervous मत हो. Just have confidence in yourself. And that's it. You know much more than what I even know at this point of time. Right? So, all the best to all of you.